Om Namah Shivaya. Good morning, everyone, and welcome back to Gujarat Criticon 2024. We are kicking off this morning with interesting case discussions, and for that, we have our judge panel, Dr. Raj Rawat. He's a consultant critical care, director at Care Associates, director critical care and emergency medicine at Sal Hospital. Dr. Gopal Rawal, organizing chairman of this Gujarat Criticon 2024 and consultant critical care at Sterling Hospital. For the first case discussion, I would like to invite on stage Dr. Shweta Gargia. Good morning, everyone. I'm Dr. Shweta Gargia. I'm a practicing pulmonologist in Ahmedabad. I'm associated with various hospitals. I have my own center in the name of Orchid ICU, Om Cardiopulmonary Clinic, and Rajasthan Hospital. Today, we will discuss about the role of bronchoscopy. Through my cases, I would like to take you to the journey of role of bronchoscopy in the ICU. So there's always a belief there is not one that IP beyond the barriers. This was a 40-year-old male non-smoker complaints of recurrent hemoptysis in the last 15 days. Supportive treatment was given somewhere in the case form of Prelixa, water base, and referred for evaluation and management. This is a CT angiography, and we can see a shadow here. So this was able to be a collapsed consolidation of the right middle lobe with GGOs in the bilateral lung fields. And there was hypertrophic bronchial collateral supplying the areas of the consolidation. Bronchial embolization was done. As a routine protocol, we went for a bronchoscopy and we could see a blood clot over here. We tried extracting it through the forceps, baskets, but nothing worked out, and finally we had to use the cryoprobe to extract the blood clot. But as we know that hemoptysis and bleeding is a complication of cryo. So after the post-clot removal, there was continuous air bleed. And we could not, it could not be controlled with Fugate balloon tamponade, local installation of Prelixa and adrenaline, and we did a rigid bronchoscopic intubation over here. And this figured of 7 mm occlusion of the right middle lobe bronchus using the glue. And hemostasis was attained. The patient was extubated and shifted to the ICU. So this is the swigot, and this is how it looks after post-glue installation. After various investigation, what came out to be positive was anti-synthease antibodies. And it was a diagnosis of autoimmune diffuse alveolar hemorrhage. And usually in such cases, we think that it may be tuberculosis or some kind of infection, but it was an autoimmune disease. We gave the patient pulsed immunotherapies like steroids and cyclophosphamide, and there was no recurrent hemoptysis with complete resolution of lung infiltrates. And the patient was discharged with intubation. Going to the second case, this was a 20-month-old baby with a history of accidental aspiration of groundnut 2 days back while eating. The patient presented with fever, persistent cough, and breathlessness, and was referred for further evaluation to us. And through bronchoscope and using the Eurobasket, it is not always necessary to use a cryo. We could retrieve the foreign body. So this was the X-ray before the procedure, and we could see an infected foreign body over here. And using a Eurobasket, we could retrieve the foreign body. Now again a baby. It's a series of
What is the conclusion of initial two case?
So it was a complete sudden onset of right calf shortness of breath and history of inhaling and screw. We can see a group in the hereditary bronchus, and this is what we could retrieve. So actually, why we were discussing all these cases was to see what is the indication of the bronchoscopy in the ICU, what is the need of an intervention pulmonologist over there, and how safe is doing the bronchoscopy, and what can be the indications, what can be the complications which can be seen in an intervention pulmonology.
Yeah. So, what are the common indications of bronchoscopy in the ICU?
It can be in cases of non-resolving pneumonias, or we are expecting it to be back, or nosocomial pneumonias, pneumonias in immunocompromised patients, patients who are on chemo or chemotherapies, or it can be diffuse or focal disease, or we are getting a it can be localized bleeds or sputum, or a tracheoesophageal fistula. Or nowadays, lung transplant has become so common. To see whether there is a need from a stump or not, a bronchoscopy can be done in the diagnostic. There are certain indications of the therapeutic requirement also. So it can be seen whether what is the position of the endotracheal tubes over there. If we want to do a selective lung ventilation, then also we need a bronchoscopy to put the ET in a selected area. Then it can be atelectasis, which can be due to some mucus plug or a foreign body. Apart from that, if there is a massive hemolysis, then a bronchoscopy is.
What are the risks of doing bronchoscopy in massive pneumonitis?
In massive hemolysis. So the risk is that since the airway is always compromised when we introduce a bronchoscope in the airway, so ventilation is always a risk. The patient may have hypoxemia, the patient may go into spasm, and if there is a clot and we are trying to remove the clot, there is a chance of rebleeding over there.
Okay. And just explain, tell me the respiratory mechanics change while you are performing the bronchoscopy ICU patient, because ICU patient already is a compromised patient, and doing bronchoscopy we are just adding on risk. So what kind of precautions we have to take to do the bronchoscopy in an ICU patient?
So very well asked question. So this is a diagram which shows a bronchoscope of three different sizes. So A is a thin bronchoscope, B is somewhat bigger than that, and C is the biggest bronchoscope which is available with us. So it shows the area cross section of the trachea with the bronchoscope over here. So usually, as bigger the bronchoscope is, more the resistance will be there. Apart from it, if we use a smaller bronchoscope, then the chances of smaller working channels, less suctioning will be there, and our work will be hampered. And same to the what are the changes? These are the mechanics that the FRC is reduced, the vital capacity is reduced, tidal volume is reduced, FE even decreases, and even the small airway function is reduced. The peak CO2 increases for a certain time, but it comes to the normal baseline value after 15 minutes of the bronchoscopy. PO2 decreases, tidal volume decreases, and the cardiac output decreases. But all these parameters comes to a normal, almost normal baseline post 15 minutes of the bronchoscopy. So if we evaluate the risk-benefit ratio of the bronchoscope in an ICU or a mechanically ventilated patients, we always have to evaluate it by the risk-benefit ratio. But there are no absolute contraindication of doing a bronchoscopy in an ICU or a mechanically ventilated patients.
Okay. In the first case, you mentioned that patient has a blood clot. So you have suspected that it is autoimmune DH because of anti-synthesis antibodies. So why you suspected such a rare disease?
So we could see that there was a bilateral GGOs and it was not a localized disease. So when we see a bilateral diffuse disease, We always suspect it that it can be a vasculitis or some kind of infection. So we send an entire panel for it, and we don't send it all everything all of a sudden, but step by step we do the evaluation, and finally we got to this diagnosis.
So, see, uh, the case, as a case, you have to mention the differentials. What are the differentials? Directly, we are just going to the diagnosis, which is very rare, right? So, blood clot can be so many conditions where you can find blood clots in ICUs. Even repeated suctioning, the patient who are on ventilator for a longer time, patient is on repairing, so many things. So, rarely. The second case, what you mentioned about the foreign body removal. Suppose in this case, by chance during scoopy, that it got fragmented and it still go more distally. So how would you manage? Or is there anything that you can prevent the further?
So if we get a chance and we can insert a thin tube that is called the Fogarty catheter, then we always try to put a Fogarty catheter below the foreign body and inflate it. So the benefits of inflating a Fogarty balloon is that first the foreign body will not go inside. It will be pushed outside, and it is easier to hold it with the various instruments. So we always try to put a Fogarty balloon before extracting any kind of organic foreign body which has chances of getting removed.
Suppose you are removing it and it stuck in the trachea, flexible part of trachea. How will you manage?
So usually we do not get like once the more chances are that it gets stuck in some of the lower airways rather than in the trachea. हाँ, लेकिन अगर if it gets dislodged in the trachea, then again the same procedure we use the various instruments to retrieve the foreign.
Thank you.
Thank you, Dr. Shweta. Now I would like to call upon stage Dr. Darshit Chauhan for the next interesting case discussion.
Good morning, everyone. I'm Dr. Darshit Chauhan. Today we are case presentation on to intubate or not intubate the case. The history is like 65-year-old male known case of hypertension presented with complaint of fever cough since 4 days. Initially, patient taken treatment on OPD basis. Patient hospitalized with complaint of breathing difficulty, hypoxia. Initially kept on O2 mask, but because of tachypnea and hypoxia, patient kept on NIV in emergency. On examination, patient was drowsy but arousable, tachypneic. On auscultation, bilateral crepitations present. On investigation, patient was having neutrophilic leukocytosis, thrombocytopenia, high CRP and high ESR. ABG was showing pH of 3.7.37, PCO2 42.9, PO2 82.9, bicarb of 24.3 and SpO2 of 96.4, with BiPAP of 100% FiO2 and PPO of 5. This is the X-ray. This is a CT scan. Requirement of invasive ventilation and prognosis. Relatives did not want to put the patient on invasive ventilation, so we continued with the NIV support after taking consent from the relative. Except for COVID-19 and influenza RT-PCR set. On day one, patient started on piperacillin, tazobactam, doxycycline, fluid. Dexamethasone started because of respiratory infection. Gradually, FIO2 tapered from 100% to 60% with target SpO2 of 90%. H1N1 influenza A report came positive on day 1. Day 3, total count decreased to 10,600. Continued with the same treatment. Bipepticum was static with FIO2 60% and PIPO 5, with SpO2 maintaining around 90%. Day 5, due to the worsening of hypoxia, gradually PEEP increased to 10 with FIO2 60% with target SpO2 of 88 to 92%. As patient was agitated, infusion started to calm the patient. CBC was showing hemoglobin of 14, total count of 6,000, decreasing from 10,000, platelet count of 1,70,000. CRP decreased from 10 to 3.8. Injection Forcan added for antifungal coverage. On day 8, antibiotic de-escalated in view of decreasing total count and CRP. Tablet cefuroxime started, FIO2 tapered to 50% and PEEP from 10 to 8 gradually. Intermittent trial of NRBM given, which patient tolerated well. On day 10, gradually duration of NIV decreased and duration of the NRBM is increased. On day 13, trial of continuous NRBM given, but patient could not tolerate it. So HFNC started with 70% FIO2 and 60 liter flow, 60 liter per minute flow. Patient tolerated the HFNC well. This is the X-ray on day 13. On day 14, patient shifted to the ward with continuous HFNC support with FIO2 of 60 and flow of 60 liter per minute. In the ward, HFNC continued for 6 more days. After that, intermittent NRBM trial given. Gradually, O2 was tapered, and on day 23, patient was continued on face mask with O2 at 3 to 5 liter per minute. On day 26, patient off O2 discharged successfully on stable hemodynamics. So, not all severe hypoxemic respiratory failure with severe ARDS need intubation. With vigilant monitoring and nursing care, patient with severe hypoxemic respiratory failure can be supported with non-invasive ventilation without needing invasive ventilation. So, what not to learn from this case? Not all patients with severe ARDS can be managed with non-invasive ventilation. Proper patient selection is must to avoid the delayed intubation and its complication. So, what are the benefits of NIV? It avoids the complication of intubation and mechanical ventilation, like reduce the risk of ventilator-associated pneumonia, improve the clinical outcome, like reduce mortality and morbidity, reduce ICU and hospital stay, and reduce the cost. The requirement for successful non-invasive support is the cooperating patient who can control their airway and secretion with an adequate cough reflex. Patient should be able to coordinate breathing with the ventilator and breathe unaided for several minutes. Hemodynamically stable, pH more than 7.1 and PCO2 of at least less than 92 mmHg. Patient should ideally show improvement in gas exchange, heart rate, respiratory rate within first 2 hours. So what are the advantage and disadvantage of NIV? Advantages are like preservation of airway defense mechanism, early ventilatory support, intermittent ventilation, patient can eat, drink and communicate, ease of application and removal, patient can cooperate with physiotherapy, improve the patient comfort, reduce sedation requirement and avoid the complication of intubation. Disadvantages are like mask is uncomfortable, problematic for claustrophobic patient, time consuming for medical and nursing staff, slower the correction of gas exchange abnormalities, airway is not protected, and no direct access to the bronchial tree for suction, and eye irritation can also be a problem. So when to intubate the patient? So there are some parameters which predict the failure. So in hypercapnic acute respiratory failure, pH less than 7.3, there is no increase in pH by 1 to 2 hours of NIV support, no decrease in respiratory rate by 1 to 2 hours, or lack of cooperation can be a predictor of failure. In hypoxemic acute respiratory failure, PF ratio less than 200, minimal increase in PF ratio by 1 to 2 hours, age more than 40, ARDS, community acquired pneumonia or sepsis, multi-organ failure are some of the predictors of the failure. So criteria for terminating NIV and switching to mechanical ventilation: worsening pH or PCO2, tachypnea, hemodynamically instability, decreased level of consciousness, inability to clear the secretion, and inability to tolerate the NIV. So what are the evidence? There is an article published in the International Journal of Critical Care, Non-Invasive Ventilation in Acute Hypoxemic Respiratory Failure, a systemic review and meta-analysis. This is an analysis of 9 studies. NIV showed significant protective effect for intubation in immunocompromised patient and in patient with acute pulmonary edema and community acquired pneumonia. There is another article published in GM in 1998, a comparison of non-invasive positive pressure ventilation and conventional mechanical ventilation in patients with acute respiratory failure. This is a prospective randomized trial. Conclusion was that in patients in acute respiratory failure, non-invasive ventilation was as effective as conventional ventilation in improving gas exchange and was associated with fewer serious complications and shorter stays in ICU. In this trial, patient with complication was 21% in invasive ventilation and 12% in non-invasive ventilation. And sepsis is also more common in intubated patients than in the non-invasive ventilation patients. This is another trial published in DMJ, non-invasive ventilation for acute hypoxemic respiratory failure, a propensity match cohort study. It compared with early intubation. NIV use was associated with more ventilator-free days in patients with hypoxemic respiratory failure. However, this did not translate into the shorter length of stay or reduced mortality based on our single center experience. So this is a single center trial, so we cannot rely upon it. So we required more randomized control trial for more evidence. So conclusion is key factor in success of NIV is careful patient selection and rejection, skilled initiation and application, algorithmic approach in initiation, use and discontinuation, patient comfort, avoid dysynchrony, avoid complication, and most importantly, decision making on when to switch to the invasive mechanical ventilation.
So, what triggers you to intubate this patient? In the first slide, you have mentioned that we have concern, we have convinced relative for the intubation and they refuse. So, why you want to intubate this patient?
10 pip. So ventilatory requirement or there are higher chances that patient will require intubation in further. So it is better to intubate early than to continue with the NIV support.
So, you have not shown the second ABG. Usually, what we do, we initially put on NIV, then after 1 October, we do ABG, repeat ABG, and then we take a decision. So, there was no another ABG. Do you have any ABG after that?
Improving the ABG was improving, that's why we continue with the NIV support.
That is an indication for NIV.
Continuously.
Predictors of successful NIV.
Improving pH, improving PO2, PCO2 in hypoxemic respiratory failure, increasing PO2, stable hemodynamics, patient is conscious.
Predictors in suspecting that this patient will be benefited with the NIV, and this patient you have to be very cautious putting patient on NIV.
Patient with hypercardiac respiratory failure, like COPD patients are more prone to get out from the NIV, not requiring intubation. But patient with communicable pneumonia, severe ARDS, PF ratio less than 200 can mostly need the intubation. There is a predictor that this patient will require. Thank you. Thank you very much.
Thank you, Dr. Darshan Chauhan. I would like to call upon stage our next candidate, Dr. Parth Shah.
A very warm good morning to all dignitaries and delegates. Thank you, ICCM, for giving me the opportunity to present this case. After having many interesting cases, my case might not be that interesting, but there were many challenging we faced during this case. So I'd like to present this. Could not get a proper title for the case, but I got this picture. It was a dilemma between heart and brain throughout the case, which we needed to tackle. And the case began with a call late in the evening that you are actually receiving a patient, 60-year-old lady, which was taken for CT myelograph for CSF rhinorrhea. She had a query seizure, query anaphylactic reaction post contrast and needed a secure airway, so she was intubated. She is now in inodrops and we are shifting the patient. On receiving the patient, we see a 60-year obese lady with a ET tube, having myoclonic jerks involving whole bodies was started on pentamidas, hypotensive with a high sugar, tubes and line in situ. And more importantly, there were anxious relative accompanying, which is a very common scenario in India. Uh, the events which was happened so far was patient was evaluated by a physician for CSF rhinorrhea and she was advised for CT cystoscopy. She was taken there and she had the events, so she was shifted nearby ICU, where initial resuscitation was done. She was given inotropes and fluid for very shock, but the intensivist there did a echo and found out there was RWMAs and decreased LV function, so inotropes were added. Routine investigation done showed increased total count and high non-gap metabolic acidosis. So, initial assessment, we found out that she had no previous comorbidities. She had similar episode of CSF rhinorrhea 15, 17 years back, which was managed conservatively. No stomic cause. In current illness, she had a fever, headache since 5 days. Again, a CSF rhinorrhea was there, and for that, she was advised for CT myelography. The main history was she was taken walking to the city. Our initial assessment showed continuous myoclonic jerks. Anti-epileptic loading was done. For persistent low BP, titration of inotropes, adding of inotropes were done. Broad spectrum antibiotic was added in view of history of fever and query meningitis. Steroid was given still because there was a possibility of anaphylaxis. Repeat echo was done, which again showed RWMA. A cardiologist was available, so he evaluated the detailed echo and showed decreased EF. The PROPI was sent, which came out to be strongly positive. Upper threshold is 20, it came out to be 19,000. Again, the creatinine, all routine investigation was done, and which shows high creatinine. She had not had any urine output since even till we received. So the expansion of team was done. A neurologist was involved. His initial assessment showed possibility of hypoxic ischemic insult. Standard care was advised, and he said that the prognosis might be guarded as there is myoclonic jerks which are not controlled by the sedations we had tried so far. But at the same time, the cardiologist put forward a possibility of ACS, added the antiplatelet in standard treatment, and showed wish for invasive supports and intervention if the relative agrees. So here came the first dilemma. What if the neurology doesn't improve after the invasive interventions and we came out, we are nowhere? And what if we don't do anything and we miss the window of revascularization? Discussion was done among the team. There were three possibilities of events which was put forward. Maybe she had an anaphylactic reaction, contrast, went into shock, hypoxia, and then the brain and heart insult. Maybe she was having sepsis, meningitis, shock which was not picked up, had seizures, hypoxia, and then the cardiac event. Or the stress of MRI sepsis led to a cardiac event first and then the hypoxia and the other sequences. The briefing was done to the relative with all possible sequences, current status, and what our experience says with myoclonic jerks that we have a poor outcome. And, risk and futility of the intervention, invasive interventions were explained. After gaining the confidence, we buy a window of 24 hours and we convince the relatives to put IABP to support the heart at least. By the midnight, we could stabilize the jerks by benzodiazepine and muscle relaxant infusions. Inotrope was titrated to keep the MAP above 70. IABP was inserted uneventful. The reactions we opened till the morning was we could win off the inotropes from triple inotrope support to a single inotrope. She started having urine output, the jerks were settled, but she was just responding to pain. No clear-cut improvement in neurology. So second neuro opinion as per the relative wish was taken. Again, the same verdict or the same suggestion was done that we should wait as she might have a guarded prognosis. Then again, the second dilemma, whether to go for intervention because we are not clear about the neurodeficit which she might have. And in the view of AKI, the angios and contrast again can cause similar reactions or worsening of the AKI. So the second discussion took place the next day, and we decided to wait for one more day to give a chance to neurology and AKI to improve before going for any further cardiac intervention. So the day two, we did some interventions. Midas was started tapering so to see for the neurology. There were no seizure activities thereafter. Urine output started improving. We kept a nephrologist in the loop. On other investigations, he was found to be first MDM. That is why the first RPS was high. So we started managing the sugars. Total count started reducing, and CAG was planned next day. On day 3, CAG was showing a culprit vessel LED long segment involvement with renal angiosperm, renal artery stenosis. So relative were convinced, despite some restraints financially, we could do the PTCA, and the reactions were great. We could taper off the inotropes, good urine output, no seizure activity. Patient started gaining consciousness. She was opening eyes to pain. And we started the weaning modes of ventilator. By the next day, we could keep her completely off sedation. Neurology was much better, not fully conscious, but yeah, it was much better than what we had received. So again, there was a dilemma whether to remove the IVP first or to extubate the patient first, because she was not yet conscious enough to maintain the airways. But plan for extubation was done before removing the IVP. Extubation could be successfully done. She was observed till evening, and in evening we could remove the IVP. Sensorium improved further. Now the initial assessments of query meningitis and CSF leak were still hanging around our head, so we added ID reference, upscale the antibiotics, and decided further plan. The next few days went well. She improved every aspects, and she was shifted out of ICU. The other concerns which were taken was by from neurosurgeon, ENT, and the point of view for serious biometric, but relative had shown no eagerness to go for any intervention now on. So she was managed in the ward till the antibiotic course was over. And, she could finally be discharged on day 15 with supportive care, AEDs, and with the patient satisfaction that we are taking her home back. So the lesson we learned, be prepared for the worst. Murphy's law that mostly at worst times, because CT system is not usual procedure. So you have to be prepared for complications when you are going for something adventurous. Be proactive, because time is essential. You have to act quickly. If you miss some of the windows, then you might not get the result what you expect. But at the same time, you have to give time a time. Some things require time for the improvement. If we had not waited, the neurology might not have improved, or AKI might have worsened. So during the whole course, one thing which I learned from my teachers is don't lose hope, and don't take that one thing which patients have. We very frequently counsel the relatives to kept on going for certain things. We push the relatives, and we could get the result. Teamwork always works. When you lack your knowledge, always be free to ask for help. And if you work in a team, you get the best results. But every team needs a captain to decide when to act. Intensivist, you have to be that captain. You have to lead and not to fall in the trap of Vikos, who will be the captain of the ship. Most of the team members were senior to me, but as a primary consultant, I had to take some decisions, and we could manage it very well. Thank you.
It's a good case, Parth. So, what is your impression? Now tell me, why the patient said all this?
So we did a serial profiles. Day was the profile was around 1,000, and the 19,000 which was we obtained on the day second. So our hypothesis was that patient had a sudden rise of hypertension because of renal stenosis, and that led to cardiac event, and that led to hypoxia seizure, which like as an anaphylactic reaction, because it was at the time of CT system. So primarily a cardiac event that led to the other sequences.
Okay. So, do you feel that it's still a primary cardiac event if you prefer to do a early revascularization in this patient? Because this patient, I think, on the third day,
Yes, we
from
did.
PC.
Yes, yes.
So, if with the proper counseling, if you could have done this before,
Yeah, we could have, but actually, with drop supports at the neurology at day one, even the cardiologist was hesitant to go for the CA because myoclonic jerk, as we know, it's a poor prognostic sign for hypoxic ischemic damage, and we did not have any other evidence to.
so why you are suspecting marker jerks? Because this patient, the patient is not have arrest or
Yeah, she did not have any arrest, but yeah, she had hypoxia for quite a long time because the CT which took almost 20-25 minutes, uh, hypoxia remained there for maybe 2 to 5 minutes because the standby anesthetic was done at city center, but they had a backup anesthetic, but they did not have the enough facilities to initiate the ventilation as quickly as we do in hospital setups. So we were assuming that there might have been prolonged hypoxia and hypoxic injury.
with a 4 or 5 minutes of even with a 4 minutes of CPR, you don't have a, such a severe hypoxic brain damage.
Yes,
This patient did not have, you didn't have any cardiac arrest, right?
yeah, we did not have any cardiac arrest.
We have a history of CSF rhinorrhea, headache, fever. So why are you suspecting hypoxic brain damage?
I don't have answers to this.
Because this is a crux at that time.
Yes.
See, with a joint with neurology and cardiology, you can able to convince the relatives that this is a primary cardiac event.
Yes, but on our team, the neurologists had a conservative approach that we should wait for at least 24, 36 hours to wait for the neurology before going for any cardiac intervention.
Because see, initially you were mentioned there is RWM and after one day the ear drop was 50%.
Yes.
So that we could have prevented.
Yes.
Okay. Another thing, in a myoclonic jerk, you have mentioned that you have given a fentanyl infusion. How it helps?
Sir, considering the status epilepticus, we started with the midas infusion, not for myoclonic jerks. We had given the anti-epileptics, but the jerks was not getting settled. So considering it could be a status epilepticus, we started with the midas infusion.
Has any EEG done on?
The EEG was done. It's just showing diffuse involvement metabolic origin. So maybe because of meningitis, she was having encephalitis, having seizures, possibly. We did EEG. I have not mentioned, but we did EEG.
What antibiotic patient is on?
So we initially started with out of which it was created was high. It was 3. So murolinic was given and ampicillin was added. She was first time diabetic, so antifungal was planned, but she improved with the antibacterial, so we continued with the same. We did a sweat CS. CS was advised by the neurologist, both the neurologists, but as she underwent the cardiac revascularization, she was on heparin and dual antiplatelet. So CSF was again a risky procedure to explain relative that she may have a paraplegia. So CSF was not done, but CSF rhinorrhea, we did a packing and then we sent those samples for CS. Unfortunately, we did not pick up any organism, but we tried to send CS and find out the organism.
Do you feel that this can be because of antibiotics can may cause?
It was given later on, sir. Before the event happened. She was not started on antibiotics till she went for the investigation. It was started when she arrived to us.
Just last question.
Yes, sir.
Whether in this case joint counseling of
Yes, it was done, sir.
neurologist and cardiologist.
Yes, sir.
That makes, because most of time what happens, I take round and I counsel, the neurologist came then. So such patients, if any joint counseling.
Yes, the joint counseling was done. The 2 discussions were done with all 3 doctors and the family members, cardiologist, neurologist, and me. So all discussions were done with the joint as a joint counseling. which helped us convince the relative that you should go for the further treatment. So, thank you, sir.
Yeah.
Thank you, Dr. Parth Shah. Now I would like to call upon stage Dr. Bluti Patel for her case discussion. Good morning, everyone. So many interesting cases to bring. Mine is a referred case from a primary care hospital. 35-year-old male had a history of RTA yesterday, and they gave us information that patient has right lower limb crush injury and CLW on occipital region. So patient came to us, we received the patient, and this was the initial assessment. Patient was unconscious, pupil was bilaterally equal and reactive with GC score of 8, E1, M5 and B2, tachycardic, hypotensive, hypoxic with paradoxical breathing and bilateral air injury decreased in both. Anuric, 300 ml urine pass since 12 hours, right below knee crush injury with distal pulsations absent, right upper limb, left upper limb no movement, left lower limb movement to pain with power of 1 by 5 and right upper limb movement to pain with power of 3 by 5. So as per initial resuscitation, patient was intubated, ventilator support was given, on controlled mechanical ventilation, fluids were given. And meanwhile, the investigation suggested with altered RFTs raised urea create CPK total of 9,500, urine for myoglobin more than 1,200, hemoglobin platelet all were decreased, D-dimer were raised, ABGA showed compensated metabolic acid. Now, patient was sent for scans. Brain showed hypodense area, which was suggestive of acute ischemic infarct, but there was no cerebral edema, midline any hemorrhagic lesion. Abdominal scan showed bilateral adrenal hematoma, no deep fluid or collections. CT thorax showed bilateral rib fracture, displaced, and hemothorax, bore on right side, approximately 300 mm. That was it. And the whole spine was then normal. We couldn't do we couldn't inject dye, but we did a Doppler which showed right popliteal, posterior tibial, anterior tibial, dorsalis pedis having triphasic waves, but with decreased velocity. Maybe due to tissue, soft tissue injury, which is imposing on the artery and decreasing the flow, but the venous Doppler was normal. The left lower limb Dopplers were normal. Then a multidisciplinary team was involved: orthopedic, neurologist, intensivist, nephrologist, and pathologist, and blood bank. The relatives were general condition was informed. Everything discussed regarding the limb salvation, amputation, the risk of surgery in view of AKI, liver injury, coagulopathy, and non-hemorrhagic. So, while this was done, the treatment meanwhile was fluid resuscitation, blood products, ICD insertion, and ventilator management. Patient became hemodynamically stable with mean arterial of 70 achieved. Urine output started, it was established, but still patient had raised all this. Patient orthopedic cortical call that surgery is to be done with ASA grading 5. Patient was operated. Operative time was uneventful. Patient was brought back to ICU. Tracheostomized, ventilation continued, fluids continued, blood products as and when required according to the coagulopathy profile done.
pain management, physiotherapy. All this continued for a week. Within that week, we were able to wean off the patient from ventilator. ICD was removed. Till date, patient had no requirement of iron drops. Urine output was so far so good, but creatinine was borderline. But now fever started. So cultures were sent. I forgot to mention, we sent an initial wound culture when the patient was received. The fever started a week later. So we send up all the cultures again. That includes blood, urine, and again a operative site culture. Till this, no change in antibiotics was done yet, as because patient was hemodynamically stable and fever had just started. The operative site cultures showed growth of MRSA. So sensitive antibiotics were started. Within day 10, fever subsided, the liver functions and coagulopathy and creatinine normal. The GC score improved. It was initially of 8 with E1 and M5. Now it's E4 and M5. Browsing, arousable following verbal commands, and the power of left side improved. Left lower limb became 4/5 and left upper limb still 1/5. So, patient, due to improvement in GCS and arousability, patient was decannulated, and in view of early rehab, patient was again operated for cross-leg surgery of right lower. Uh, my lessons learned in this case is initial stabilization of patient, that is rapid assessment according to ATLS protocol, that is airway, breathing, circulation. Along with that, fluid management. Since we received patient from a primary care hospital, airway breathing was not managed there. It was managed after we received patients. So the time between the accident until we received the patient was almost 12 to 15 hours. So meanwhile, time being, patient did not receive adequate fluid. Patient's GC score was not good. Patient was hypoxic. So all this might be a triggering event for AKI. Of course, soft tissue injury leading to rhabdomyolysis and AKI is always there. But this is also a factor that patient within 12 hours couldn't receive adequate fluid resuscitation. And one more take, I would say, see, polytrauma and DIC or coagulopathies are intrinsically related, and that is a vicious cycle. If not taken care in time, this vicious cycle continues, and of course, your management gets exacerbated due to this. So, if the patient had received blood products before coming to any tertiary care hospital, then this would not be the problem of, I mean, DIC would not have triggered so much. Because I have not mentioned, but when we received patient, the INR was 5, platelet count was of 93,000. The time we took to stabilize this patient, getting an INR of approximately 2 to 3 so that we could take patient for surgery, was almost 6 hours. So for this 6 to 8 hours, what time we could save if patient had received blood products initially before coming to any tertiary care hospital. So even the primary care setup, people should know that polytrauma, managing fluids, blood products has to be taken as a primary care. Patient was referred, so we could not lose the 6 hours time for taking a patient to surgery. So that is my take. And of course, polytrauma is a multidisciplinary team approach. So every team should collaborate and work together so that the approach and outcome is good, and the mortality, morbidity, whatever we can say, can be reduced, and it leads to early rehab also. So functional recovery and transition to recovery can be managed early. So nowadays, even early rehabilitation is considered in uh, tertiary care hospital for any outcome of the patient. So that for because of that reason only we have taken a patient for second surgery of cross-flap early. Thank you.
this patient has acute ischemic stroke.
Ischemic stroke.
So is it case of trauma or how is the sequence?
No, it was a case of RTA only. Now, how did that RTA happen? We don't know. Patient's relatives said it was a slip of bike, but that slip of bike might be due to patient had stroke and that he couldn't balance it, then he had a RTA. But that sequence is not. He is a 35-year-old male, but has no comorbidities and has no any history or any familial history of such that we could diagnose a stroke early. But looking at the power of the left limbs, upper limb and lower limb, we could suspect that something is going on in brain. We were suggesting, thinking of having an hemorrhage, but instead it turned out to be an infarct.
And second, what surgery?
External fixation only of the right lower limb was the first surgery that was done, only to stabilize the fractures and the debridement of the soft tissues. That crush injury was managed.
Any vascular surgeon has
We did an opinion of plastic surgeon. He only did doctor again, and he said that all the arteries and everything are intact. Just the flow is decreased because of the soft tissue edema, so no need to do any vascular repair right now. So vascular plastic surgeon opinion was.
so now patient has a pneumothorax ability. Patient has vascular one. Have you given heparin or not?
We couldn't give heparin because initially the patient when it was received, the INR was of 5. To make the patient stable for surgery, we had to give so many blood products. The relatives were actually counseled that in one brain we have infarct, the rest of the organs are bleeding. But to save such, we have to right now forget the infarct part because see, infarct is there, but we have to save this limb saving surgery. So we couldn't give heparin at that particular moment. But yes, after the first surgery was done, patient was started on a prophylactic dose of low molecular weight heparin.
See, the patient has a history of trauma and this bleeding is because of the acute trauma. This once patient may have a DX. So whether you would prefer to track just see that there is an active bleeding is there or not.
So when we received patient, active bleeding was controlled in the ICU only. We didn't put the patient to surgery. But still, because of DIC was already triggered, we had to do.
So would you like to treat this PTI now 5 with any components or?
We treated with platelets, we treated with FFPs and cryo was not needed much, only 1 or 2. But with platelet and FFPs, we could manage blood products for
Indication for cryo.
So actually the FDP was sent and the result came back after 24 hours. So I have not mentioned that, but FDP was sent.
DIC profile was not sent.
No, it was sent. D-dimer, FDP, then PTINR, BTCT, everything was done. 5GP, 5genogen.
Damage control surgery.
So, till now we had kept the patient. Soft tissue repair was only debridement and just external fixation only. And for chest trauma only ICD was done. That was the first surgery to control the damage at a time.
Okay, thank you.
Thank you, Dr. Kruti Patel. I would like to thank Dr. Raj Raval and Dr. Gopal Raval for their time as the judge panelists.
We will announce the results of this case presentation in lunchtime.
Thank you, sir, for your time. And thank you to all the participants. Moving on to our next session is a panel discussion on passive euthanasia in India. Where do we stand? I would like to call upon stage our moderator for the panel, Dr. Pradeep Bhattacharya. Sir is one of our national faculties. He's affiliated to RIMS Ranchi. I would also like to call on stage our panelists, Dr. Srinivas Samavedan, Dr. Rajan Bagora, and Dr. Raj. Dr. Revati Iyer,
So, very good morning to you all. टॉपिक ऐसा है कि कुछ ज़्यादा लोग रहते तो ज़्यादा मज़ा आता है। सुबह सुबह का टाइम है, अटेंडेंस बहुत थीन है, but still we can have a good discussion on this topic because we know that our country is full of diversity. Despite of diversity, our unity beauty. So, passive euthanasia and India, where do we stand? I welcome our panelists, Dr. Srinivas Samavedan, President-elect, ICCM, Dr. Rajan Bhagora, Dr. Raj Rawal, and Dr. Very good morning. So, let me see this end of life, palliative, terminal care. How do we differentiate? Basically, palliative care is given to those persons where we know that yes, the patient is going to survive, or there is an unpredictability, but there are no chances that patient will survive for a longer time. And when we talk about end of life care, when we see that now probably it is defined that almost he may survive for weeks or some few months more. At that point of time, the care which we give is called end of life care. And finally, when we see that only days to hours of the life are left, at that time we call it as a terminal care. So this is how it goes on. And when we talk about euthanasia, euthanasia comes on the last part of this three cares, that is terminal care. Okay, so as I said, palliative care and end of life care, these two we have to understand. These two are different, and where we exactly apply end of life care is that when patient is terminally ill. Now, the question is end of life care legal in India? India has only one legislation concerned with the end of life currently. That is Human Organ Transplant Act 1994-2011, which is validated the concept of brain death for the limited purpose of organ donation. And euthanasia entails hastening death in patients who are in severe pain, and it is an illicit act that intend to kill the patient. So that is why there are two terminologies. One is active, another is passive. So all efforts are to provide symptom relief to the patient in end of life. And palliative care is initiated to give good quality of death to the patient. So end of life care includes palliative care and usually involves the withdrawal of life sustaining treatment. Withholding and withdrawal, these two things are now. This is the Supreme Court guideline 2018, and they gave some directive as far as advanced directive and withholding of life support is concerned. And after that, here they said that yes, judicial magistrate of first class and visit to the patient decides for withdrawal of treatment. And this is an algorithm of ICMR consensus guideline. Do not do DNAR, that is what we call, but do not attempt resuscitation, which was given by ICMR. And here it says that final decision lies with the treating physician in the best interest of the patient. And reasons for the decision should be documented, and the patient surrogates declines decision. This should be documented, review the decision. So, what are the landmark judgments on euthanasia in India? So, we all know Arna Shankar case versus Union of India. And the court declined in saying that they said we have to differentiate between active and passive euthanasia. And they said she was still alive when they had because she was not requiring any kind of life support. That is why they said, no, whatever we do, it will be called as an active euthanasia and not passive euthanasia. And currently, he is not on any life support treatment, so that is why court declined this decision. And then after that, in 2023, Supreme Court came out with a modified decision with, as far as advanced directive and withdrawal of life support is concerned. And they made it a little bit easy, and by saying that the persons who are going to certify or needs to be present at the time of advanced directive of withholding of support, they said either district collector, instead there is no need of district collector. So they said the hospital can constitute its own team, and if there is a notary or a gazetted officer is there, the purpose is solved. This is, was rectified. Now another case which came to the Supreme Court was the Harsh Rana versus Union of India. Here again, the plea was declined by Supreme Court, again saying that there is, they said we cannot entertain euthanasia in this case, and because they say the patient at the point of verdict was not required, they are not fit for passive anesthesia, euthanasia, but they require an active euthanasia. So because he was not kept alive on mechanical support, and he was very although not responding, but life support system was not there. So again, it was declined. Now this is the final pathway which we have prepared. I'm also part of it. Currently, it is with Ministry of Health. That pathway for withdrawal of life support in terminal patients, I presume it was submitted to Government of India in the month of June under the leadership of Dr. R.K. Mani. And this is basically the algorithm which we are following. And again, withdrawal of support, what are the, there is as such no change, whatever has been given by directives has been given by Supreme Court, but it simplifies the thing which has been given, the court has written on its decision as far as passive euthanasia is concerned. Now, we live in India. We come to our Indian context, and here we say that कर्म फल इंसान को तो भोगना ही पड़ता है इस जन्म में चाहे अगले जन्म में, and this is the truth. We all understand, and although we have different religions, but if you look at religions like Muslim, they also attribute the moral quality of suffering. And it's they say that the badness or evil solely to human actions, the way they do it, and everything is directly controlled by God. Thus, despite all delusions to the contrary, is perfect in design, physical pain and illness and life. And if somebody has done some bad thing, they have to suffer at the end of life. Christians also pray for those who suffer and try to help them. Evil and suffering in this life is a preparation of our heaven. So again, they say suffering is good. Every let suffering give people a chance to become better people and improve their souls. Christianity teaches that God will reward them in heaven. So if somebody suffers here, they will be rewarded. And what about our Hindu mythology? They fear bad death and have ideas about how to die well. We talk about poor karma causes bad births and returns, and karma causes hard times for individuals. The sannyas ashram helps people overcome money and emotional worries and prepare for death through prayer, reading, and meditation. And dying people can refuse drugs to die with a clear mind and use pain as an expression for their sins. So this is what our Hindu mythology says. Mentally mature people have a different desire to die than those who are in pain and want to end their unbearable life. Immoral suicide leads to hell, and good death shows how to look at it positively and not to fear it. So, with this background, so what our code says, what our society feels, what our religions feel, and everything. Now, decisions about approach and treatment should be taken on the basis of the actual customs, opinions, value, and attitudes of the individual patient, and not on the basis of predetermined simplistic construction. So, his karma is bad. That is why he is getting a bad death. It is the curse of God. Goes to panelists. What do you feel? What do you think? I have given a background just to anybody can take. Anybody wants to say something on this first aspect, because this is important as far as our country is concerned. This is important.
Hello.
Yes.
I don't believe that it is a view of the religious view. It depends your death, your birth depends on the your karma. Religious view, but as part of a science student, I believe in science. It does.
So, do you feel that yes, what court says that dominates over our culture and
What has made a very confusing guideline, I think so. Because first, the definition of death is not given specifically. There is no legal definition of death. In the act of organ, there is it is the criteria, brain death criteria regarding the brainstem death.
No, but we are talking about euthanasia. We are talking about passive euthanasia. We're not talking about death.
If we see our ethical guidelines of medical council, there is written that passive euthanasia is an unethical act. Till today, research ethical guidelines of medical council, passive euthanasia is an unethical act.
No, but now our Supreme Court has allowed withdrawal and
Those Supreme Court has allowed, but the guidelines are not very they have not simplified the procedures. What we practice in periphery, we take informed consent of the patient and we give full information regarding the patient condition and we take consent that patient, we are not going to help the patient in future. If the patient is in terminal condition, he or she is going to die, then we take informed consent. It's a very simple procedure. We are making it very complex by adding legality to this practice, which I are doing for last many years in our India.
Okay. So a dignified death.
Though for the important
It is yeah.
what in India is patient centric nowadays. It is patient centric. And there is always conflict with the rights of the patient and the duties of the doctor. In legal framework of euthanasia, the guidelines according to Supreme Court give more burden on the responsibility and duties of doctors. rather than lives.
Okay, Dr. Srinivas, what to say?
First and foremost, when you talk about dignified death, is honoring the sentiment of the person who is actually dying. That should be the prime goal, after which all other compulsions and all other legal formalities will come into the picture. I don't think
So you believe that cultural and religious beliefs should be kept as a priority rather than what court says.
what I personally feel is using the framework provided by the legal structure. We, as people in intensive care who deal with death more often, should ensure that the person, we don't become instruments in an undignified death, which is not in sync with that person's moral and spiritual beliefs. We should ensure that we can apply the legal framework and provide a dignified death to anybody as per their religious and philosophical beliefs.
So we can offer,
We can offer.
we can offer. Yeah.
Dr. Rahul.
So I think as any human beings, has a right to live. I think uh, based on their religious belief and what Dr. Srinivas mentioned, that the dignified death is a wish of not a person, even the family, because at least he should die peacefully. So at least we should have a proper legal framework to facilitate these things. No, but what Supreme Court has given, do you feel that is inadequate? As far as the guidance is concerned? Yes, yes. Still, it is a complicated. It is a complicated. No, yeah.
Hello, sir. There is one condition in the guideline. Brain death to the patient is must.
No. It is not there in euthanasia. Brain death is different. It is the organ donation.
For the transplant.
It is for transplanted organ donation. Brain death is different. We are talking about passive euthanasia. The patient is, his brain is functioning.
See, passive euthanasia is when you withhold treatment or withdraw support in a patient who is terminally ill, or a patient is not going to have a good quality of life. So what the 2018 we had a law about advanced medical directives, where the patient himself, when he is fully conscious, or one of his legal representatives could make this legal will or advanced medical directives. Only thing is, it was previously made very complicated that the judicial magistrate had to sign it. Now, with the 2023 verdict, things have become easier. A simple notary or a gazetted officer can sign it. So, things have become easier. The law is helping. Only thing is, this is for a patient who's on a ventilator on inotropic support, where by withdrawing support, we can let the patient go. But what about a patient who is not on support? Like again the Aruna Shanbhat case, where she was not on support. So we still do not have anything to help them. So we cannot give, there are places like Netherlands, Switzerland, and some places in Canada when they actually help. There is something called physician-assisted suicide, which is part of active euthanasia, which is still not legal in India. So what we have in our hands is only withholding or withdrawing treatment. So we can help only those people who are on a life support system, which when withdrawn, they can die. Otherwise, we don't have much in hands. Only thing is the practice of Dharma, discharge against medical advice or leave against medical advice, and pushing the patient home to die, that has changed, that we can help because the things are easier. A 3-member team, treating physician and 2 other members, can make a medical board and they can take a decision and the withdrawal process can be initiated.
So my question was, do you feel that religious and cultural beliefs in India dominates over what we should follow as a practice professional the guidelines of Supreme Court. Do you feel that, or yes or no?
So it depends. It depends from patient to patient.
So if somebody may come, like Jain Dharma people may say that patient is suffering from cancer, they say, let him suffer from pain, because if he suffers from pain, he is going to go to heaven. And if you relieve his pain, then he is going to hell. So that is the problem. So what will you do as a professional? What will be your approach?
We can just counsel them. We cannot force treatment on anybody.
Because these are the problems in our country. These are the not problems in other countries. Okay. Now, the second question which comes: what percentage of Indian hospital doctors are following this passive euthanasia practice or end of life care practice? I will start with Dr. Srinivas. He will tell what is happening in corporate hospital.
So yesterday in Thane, we were both in the GUJCRITICON. There was this discussion on similar lines, and there was a show of hands kind of assessment of how many people have understood the legal perspective and how many of them are actually following this passive end of life guidelines. 20%. 20% across a broad spectrum of people, youngsters, middle grade consultants, and seniors put together, maybe corporate, government, and tertiary medical practice, 20%. Now, the issue is most of these patients, in the hope of doing some miracle, will end up in tertiary care hospitals. It may be a government setup or a private setup. The tertiary care or quaternary care hospitals are the ones which will be dealing with this because we have the infrastructure to support life. So failure of such supports happens more often here. I think the understanding the whole concept of the Supreme Court's judgment and the subsequent Ministry of Health and Family Welfare guidelines has to be inculcated more in the higher end corporate and government setups for us to implement it. As is evident, there is a lot of unknown fear about these guidelines and a little bit of lack of clarity. And I feel that's the reason why.
I'll go to the audience. How many of you know this Supreme Court guidelines 2023 and Advanced Directive 2013? So 1, 2, 3, 4, 5, 6, 7. 7 or 8 hands. So if I say that 8 out of what is the percentage of patients who goes to the government hospital ratio to corporate hospital? I think it is 90s to 10 or 80s to 20. You can say here 80-20 going to government hospitals. And I'm 100% sure that because I'm also working in a government setup, nobody is aware about this advanced directive withhold of life support which has been passed by Supreme Court in government hospital setup. I'm 100% sure. They do not know anything. So that is why I'm saying that what percentage of Indian hospitals, so if we say only 20% private sector corporate hospital where the patients are dying, and there too, again, we work with limitations. There are so many limitations are there. Active euthanasia is not allowed, passive euthanasia, and where we are going to give passive euthanasia, withdrawal of support, it is, I think, at current scenario, it is really very, very difficult. Now, these are the issues. Patient's family doesn't want to withdraw support. On the other hand, they don't have money. Anybody can answer? What will you do? In a corporate setup.
So this is very clear. There are multiple judgments by different high courts and different Supreme and different district courts. No hospital, whether it's a private hospital, corporate hospital, trust hospital, or teaching hospital,
can deny treatment to a patient who deserves treatment and is likely to benefit from it on the pretext of lack of. We cannot do it. It is illegal. If you say that, if you write in your summary on financial grounds the patient is being discharged, you are liable to be taken to a criminal court, not a civil court. You are likely to be taken to a criminal court. We are circumventing it by threatening them, cajoling them, convincing them, and sending them against medical advice. That is also illegal according to Indian law. There is nothing called left against medical advice. You should not have a left against medical advice template in your electronic medical record. It is illegal. You cannot say left against medical advice, because how can you give against medical advice? How did you permit it? It is the law looks at it as a vicarious liability to ensure that a patient who is unaware of his medical condition is made aware that he will die if he goes against advice, and treat the patient. And we cannot deny treatment solely on the basis of his financial inability. If you cannot, you should make arrangements for transfer of such a patient where such treatment can be made at your responsibility and your cost to that hospital.
Agreed. So what Dr. Srinivas says is absolutely correct as far as our country's law is concerned. But what actually happens? How long you can keep such kind of patient in your hospital? Yes. Lama form. Are you listening? Huh? No. But like you mean to say that the patient, because exhausted with money, you will now ask the patient, force them to sign a Dama form and Lama form. You will force them. You force the patient. Dr. Raval, yeah.
The right to life is a responsibility of the state.
Yeah.
It's a duty of the state to take care of citizens regarding health. But there are some restrictions in the private hospitals. Economic concerns are there for private hospitals. So such patient is a case of a government issue case. It's a government issue.
Why only government? Health?
It is not fundamental, though it is fundamental right, but it is restricted to state hospitals only. State hospital only.
No, doctor, I think you are absolutely wrong. How you can differentiate government and corporate on the basis of that patient? This kind of patient will be treated only in government. This kind of patient will not be treated
in every hospital. Patient admit किया है तो उसका खर्चा बढ़ेगा. तो वो कौन देगा?
Doctor, I
there is something known as social responsibilities for the private hospitals also. Probably part of charity work should be done by private hospitals to some extent. But most of the corporates, there is a big issue. So what we ultimately do is we pull it a little bit to an extent where we can manage. After that, we make all arrangements, like Dr. Srinivas said, with a proper support in a mobile ambulance, with an ICU doctor, with a ventilator. We make arrangements in the state-run or trust hospital and safely transport the patient and hand over the patient to the doctor there. That's what we do. Like Dr. Srinivas said, it is the right of the patient for health. Whether the patient is in a government hospital or in a private hospital, we cannot deny treatment. We have to do it. If we don't, then we can be...
Yes, Ritesh? Yeah.
Sir, if Dama or Lama is illegal, forget about financial constraint. If relative says that no, I don't want further treatment, I want to take patient home. So in Dama, we don't write down because of financial constraints or something like that. So if relatives want now mujhe discharge hai, so in what format that we should?
Yes, Dama is legal. I would counter Dr. Srinivas. Relatives can take the patient to any other hospital. They have the right to choose the hospital.
It is not against medical advice. It is withdrawal of support and cessation.
It is a question of
It is not what we write discharge at request is also
Discharge on request is illegal. Dama is absolutely legal.
and patient doesn't want to go out of that hospital. He says कि
Then he will not sign on Dama.
हम नहीं sign करेंगे आपको जो करना हो कीजिए.
You cannot force him But they can take Dharma and go to any hospital which they feel they want to take.
Dharma is not permitted. Dharma is
It is
not,
our responsibility to shift him there.
Dharma is not allowed even by NABH. That is withdrawal of support. That is withdrawal of support.
So how can we make them right that it is withdrawal of support?
You can't do that.
That's
You can't do that. You can't do that. Here, the only way is that you have to keep the patient in a hospital and provide whatever support he is requiring at that point of time. You have
they want to take patient home कि आपका अभी treatment ही नहीं करा.
So that is a different situation. No, here we are talking a patient who is in end of life care. He can be given a passive euthanasia if the condition allows. And if the condition doesn't allow, like I showed two cases, like Narmada case and another. So where the condition doesn't allow, as per Supreme Court, they say no, these are not the condition where we can allow passive euthanasia. These are cases of active euthanasia. And now you start.
Dharma you say is illegal in format of only end of life care, not
Yes.
other in other form it is legal.
Here, I think.
Okay, now I think we should go ahead because now narcotics, again, this is a very important. Narcotics are a prerequisite for painless death. The hospital doesn't have narcotic license. How many hospitals do you have all from audience? How many of you have got narcotic license? Okay, quite a bit. But I see that most of the private hospitals, other than I'm not talking about corporate, private hospitals, they don't have narcotic license. Even many government hospitals, they don't have narcotic license. And now, this kind of patient is there with you. What is the way out? Dr. Raval?
Yeah, so that's what I was discussing. This guideline, it is still a very complicated. What I'm talking, I have a practical experience of this primary medical board and secondary medical board. Once we reach to the magistrate, he doesn't know anything about this. As Dr. Rajan was telling, the same thing. They don't know about all this law. We are discussing day in, day out. They are not knowing anything.
That is why we need our critical care awareness amongst the general public. This awareness is very, very.
And second thing, this our licensing. See, I think the patients who are terminally ill and they're admitted at a small private hospital, they don't have narcotic license. So that should be included into the guideline. What I mean to say.
Okay, so yeah.
So I think with your leadership, you should actually form a rule. If you run an ICU, license is mandatory.
License is
Because how do you run an ICU without a narcotic?
It is not any patient requiring passive euthanasia. I think that kind of patients are there with each and every hospital. Wherever there is a treatment center, we get such kind of patients. So we have to have, because government is so strict with this license business that it becomes really difficult. So at the companies, they are also very reluctant to supply because they don't have any margin out of these drugs like morphine, methadone. There is hardly 5 paisa, 10 paisa margin. So they also don't want to sell. So there is a big problem in between. Anyway, now this is an important thing. Law of double impact. We give narcotics and sedation for palliative care. Overdose kill the patient. And many a time it happens. On the other hand, active euthanasia is illegal. So you are giving narcotic and patient is dying. Now, sir, any comment from panelists?
मेरा ये कहना है सर, you are doing passive euthanasia or active euthanasia, outcome is same, death. It is issue of ethics. It is issue of ethics. You are omitting treatment by withholding or withdrawing. You are doing something. You are committing an act for active euthanasia. So both are the same. It is ethical issue.
Okay, what like?
So basically, we have to have maintained records that we have given narcotics in the proper dosage We have not exceeded the limit, like say if we give a fentanyl infusion for a pain relief and it has caused respiratory depression in the patient and it was not intentional and the patient dies and tomorrow the king take you to court that they did not want death, but because of your drug the patient has died. Because active euthanasia is not legal, we can get in trouble. So that is the reason when we do such a thing, we have to be cautious that we give it in such a dose that it is does not cause respiratory depression and probably keep him in ICU for proper monitoring and with proper records so that we save our skin and we don't get in trouble later in helping the patient.
Yeah, it has happened with me. One patient terminally shifted to ICU. He was in such a bad state that he has to be intubated. He was given just narcotic, 3 milligrams of morphine to take care of his severe pain, and suddenly he had a cardiac arrest and he died. But anyway, these things happen. Now, where you stand as far as court of law is concerned? You are given a drug which can kill the patient, and when an underdose at this situation, when his patient is terminally ill, decision is very difficult. Whether 3 milligram is lethal to him or 10 milligram is lethal to him, we do not know. So these are gray areas.
Yeah, so I think you have to save our skin. We have to save our skin. That's the thing. We have to be very meticulous about the counseling, about the consent, and about the clinical management of this kind of patients.
So anyway, we have then this is another thing. Can we say 0%?
No, we can't. We can't.
We can't. So then these are the issues: violation of patient anatomy. A patient lose their autonomy when they are severely unwell, and the loss of autonomy is compounded by the use of palliative sedation. Again, because the patient lacks the ability to make decision, the decision on whether or not to use palliative sedation in these circumstances can be seen as either detrimental or harmful, or not harmful. So that violates the patient's autonomy. Another thing, violation of dying with dignity and integrity. Because not all symptoms may be alleviated by sedation, it might lead to uncomfortable situation for the relatives and palliative patients, which may cause the family to feel as though their loved one's passing was dishonorable because they cannot communicate at the end of terminal care time. The non-communicable state is embarrassing for the patient's family member, who the patient's family members truly wants to remain intact during the end of life care, despite the fact the patient is badly suffering. So these are the issues. Now, these are some of the other issues which I feel, because I am working in a government setup, the patient is the only capable member who is going to take the decision of end of life care. How are you going to take the decision? So, after admission, what happens is a non-responsive patient who needs end of life care. Patient's party has fled. It happens very commonly in my hospital. पटक के चला गया तो जो करना हो करो पता ही नहीं है. We have to take the help of police. Patient's party says you are the god, whatever you want you do, but don't ask me to sign anywhere. Huh? Common situation. Patient is a prisoner, has been brought from jail. There is no family member, and he needs end of life care or passive euthanasia. Who will take the decision? So these are practical issues which we feel day-to-day life. I think it's not just a 40-45 minutes discussion. If we have every point, we can have endless points on those. We can have a huge discussion all day. We can have debates on these points. I think I must thank the panelists because time is over. We could not take any further questions, but I have given many questions to you to think over so that whenever we come for the debate next time, at least we should have some answer with us. Thank you very much.
Thank you, Dr. Pradeep Bhattacharya, for an interesting and engaging session. I would also like to thank our panelists, Dr. Raj Raval, Dr. Revati ma'am, Dr. Rajan Bakura, Dr. Srinivas, sir. Now moving on to our next session, I would like to invite on stage our chairpersons, Dr. Harendra Thakkar, consultant pulmonologist, Ahmedabad, and Dr. Anish Joshi, Narayan Rudralai, Ahmedabad, and ex-chairman ISCCM. I would like to call on stage Professor Dr. Brandon Madden. He's our international faculty. His session is on difficult airway algorithm.
Morning, sir. Welcome to 10th GUJCRITICON. I will not introduce in detail because all of us know you. We will start the lecture on difficult airway. Thank you, sir.
Be here and just get thank you very much. It's an absolute privilege to be here. I promise I will not exceed time and we'll go through the clinical slides within certainly about 20-25 minutes for those of you who are tired and want a cup of tea. So I promise I won't be overrunning. It's a great privilege to be here, and I'd like to thank the organising committee very much and my chair people this morning for their intervention. But it's always a privilege to come to India. And again, I'm very, very honoured to be invited by the committee. I think they've done a fantastic job. I'm just going to do two things this morning. The first is to show you a difficult airway scenario that we had and to share some views about it. And then the second, the committee asked me if I just share the current difficult airway algorithm that the UK Difficult Airway Society published and presented in around 2016. So this is the, first of all, the clinical case. So the lady that we had was 59 years of age. She'd had squamous cell carcinoma of the tongue, and that was the classification. The lady had a high body mass index. So she had a right partial glossectomy and bilateral neck dissection. Unfortunately, I know very little about head and neck surgery, so I'm not familiar with the 1 to 4, but the experts, the max experts, tell me that that's essentially dissection the length of the neck, both sides. So before this lady started, she was a very difficult airway in view of her cancer, the surgery she had, which was a forearm interposition graft, and the fact that she had had a recent surgical intervention. So she had a tracheostomy, and this whole operation took 11 hours. So she goes back to the ward, intensive care, and she was doing very, very well. She had a hematoma in her neck, and that was evacuated, but then the tracheostomy got dislodged. And when the tracheostomy got dislodged, the anaesthetic team, who were superb and saved the good lady's life, put the tracheostomy in very quickly. It was an emergency situation, but the patient developed a significant tracheal injury. So the poor lady had head and neck surgery, so her partial glossectomy with a forearm graft. In addition to that, she had a high BMI, so there was no access from the top end. So we had to go through here. The tracheostomy, when it got dislodged, caused surgical emphysema, and she basically blew up. This just shows you her lungs. I mean, all of you are very familiar with the concept of baby lung, but you can see this lady's lungs are tiny on CT scan. And you can see a lot of surgical emphysema around the trachea, in the head and neck area, and going up above the shoulders. So this poor lady was in a very difficult situation. This is just another CT image. You can see the degree of extrinsic compression by her high body mass index and also the emphysema and the relative shrinkage of the lungs. So she was very, very difficult to ventilate, and this was clearly a very unstable situation. So our colleagues said, what can we do? I mean, we can't leave this now with the tracheal tear. And that just shows you that looking down through a rigid bronchoscope, through the tracheostomy side, that just shows you the tear in the posterior mediastinum. You can see it projecting upwards. That's a very common situation when you get a tear of bougie in intubation, or if there is a tracheostomy-related injury or a tube injury, you can get a tear, a longitudinal tear in the membranous trachea, and you see everything is bulging inwards. So just as you look on the top, the cartilaginous tissue is the top end, and then the membranous trachea, instead of being flat, it's cut and puckered and coming up like this, like a little mountain triangular area. So that was where the defect was. And the problem we were faced with was, how can we fix this? So what we did, we took the tracheostomy out, put the lady on VV ECMO through the femoral cannulas in both femoral veins, and then put a fiber optic bronchoscope in first through the hole to look at the anatomy. When we determined what the anatomy was, we put a rigid bronchoscope through the hole in the neck, very carefully down into the trachea, and lifted the trachea forward. And then we determined what the problem was here. That's just another image. You can see the trachea is all distended, and there's another tear you see to the right with some blood in it. So it looks like that there are two almost like gutters in the trachea. So we felt that we had to seal that. Now, we didn't feel that this lady, given her background and all that was going on, would be a candidate for formal tracheal surgical intervention. So we decided we would put in a stent through the rigid bronchoscope. So flexible bronchoscope was passed through the front of the neck when she was established on ECMO. The rigid bronchoscope, with knowledge of anatomy, was then put through the front of the neck. The bronchoscope was taken out, and then we put in a stent. And then one of the things I would say to you, not that I hope you would ever see a case like this, but if you ever have someone with a tracheostomy and it gets dislodged, a really, really, really good way of getting it safely into the trachea is, don't go blind. Get a fiber optic bronchoscope if you're in intensive care. Put the fiber optic bronchoscope through the tracheostomy and use the fiber optic bronchoscope like a bougie. So stick it through the hole, have a little look, make sure you're in the trachea, and then slide the tracheostomy tube over. So that's what we did in this situation. Once we had the stent in place, we then got a tracheostomy tube, we put it over the flexible bronchoscope, put it through the defect, and then just very gently just put the tube under direct vision over the bronchoscope into the stent. And that just shows you the picture. So you can see that's the carina, and this is an expandable covered metallic stent, because we felt a silicone stent would not be a good option, would migrate. This was a life-threatening situation. That was done in 2023 in July, and it was presented at the American Thoracic Society earlier this year. And the lady remains very well now. She goes to the gym, she's lost an awful lot of weight, and now, a year and 4 or 5 months on, she's making very good progress and is doing well. Now, obviously, this is a very rare situation. I had never seen this before, and we do, as Dr. Manoj knows, who works closely with us, we do loads of these kind of interventions, so it's rare. But it was just really to give you a little insight as to the so-called difficult airway algorithm and approaches available. So she was discharged from hospital 6 weeks later, and as I say, she's doing well. I just wanted to just show you a few little techniques before we look at the algorithm. Just a few little simple techniques. These stents are put in, and we do it, just checking the laser pointer working, so I apologize. But they're put in on these applicators. So the stent is the black bit up at the top on the left. And what you do, you either can put it through with flexible bronchoscopy, and I know that you're blessed in this great city with very skilled men and women in flexible bronchoscopy, But we tend to do it at rigid bronchoscopy. So basically, you put in a tube into the airway, you put that white introducer through, and when you look at the position and make sure it's in a satisfactory position, you see there's a little yellow circle. You pull on the little yellow circle, and the stent, it pulls a string, and the stent just opens out. A little bit like the old-fashioned ships that people used to put into bottles. They put them in with string, and then you pull it. So it's very handy doing this under rigid bronchoscopy because we're blessed with brilliant anaesthetists and the patient is paralysed, sedated, and not moving. It's more of a challenge if it's done under flexible bronchoscopy. But certainly the last 500 or 600 of these that we've done under rigid bronchoscopy, the median time to put the stent in for the whole procedure is about 10 minutes, so it's quick. And if patients are compromised, you want to be quick. But it's a team approach. So that's how the stent goes in. It goes in this long applicator, and then you just pull back on the yellow circle device. That's just a close-up. The actual stents are made of nitinol, and they can be covered or uncovered. The uncovered stents interfere less with mucociliary clearance, and they're usually put in for extrinsic compression. So a big thyroid or lymphomatous tumors or big TB nodes, for example. Whereas, or if you have a hole, for example, a tracheoesophageal fistula, the covered stents, the uncovered stents interfere less with mucociliary clearance. The covered stents have the benefit of preventing cancer growing through or of sealing defects. The word of caution is that when you put these things in, they're usually considered to be permanent. You can take them out, but it can be a challenge. So usually if we're putting these things in, we do so on the understanding that it's a permanent treatment, that the patient is not going to have that removed. So therefore, the vast majority of people who have these types of stents have underlying malignancy. And that's what it looks like there. And they're very, very effective, and they're very straightforward to put in, particularly under rigid bronchoscopy. I always say to people, our local chest colleagues, pulmonology physicians who do it under local anesthetic, that rigid bronchoscopy is easy, and they think I'm trying to be humble, but I'm not, I'm being honest. We've got brilliant anaesthetists, nurses, ODPs, recovery staff, a theatre space. The patient is asleep, we've got an airway, the patient is paralysed, they're not moving. So actually, it really is very straightforward. When the people are doing these under local anaesthesia, it's a lot more challenging. The patient's awake, the airway is compromised, and they may be coughing and so forth. So it's a lot more challenging. But as I said, once these things are in, they're usually considered permanent. One of the things people asked me to mention a while ago was if you get holes in the airway, for example, TB fistulas, tracheoesophageal fistulas, injury from trauma, bougies at the time of intubation. Particularly, we saw that during COVID, where people have persistent bronchopleural fistula after lung surgery, lung resection, then you can seal it with glue. And what we do is we get glue, this is bio glue, and you put it on little gauze pledgets, and then you stick it down through the rigid bronchoscope and literally seal the defect. And again, that can work very, very well. All of these things that I'm describing, we have the privilege of publishing, so it's in the literature. And this is the sort of material. Unfortunately, it only comes with a small mixing device. There are two parts, and you have to mix it, and then as soon as you mix it, you have a short period of time, and then you put it on gauze, put it straight onto the defect. That gets quite hard. Just one or two of your colleagues talked about airway malacia. Can you treat airway malacia with stenting? You can do if it's localized, but if it's extensive, in other words, beyond the trachea and the main bronchi, going down to the middle and lower lobes, if you have that kind of picture, stenting doesn't work. So you cannot put in what's called the full metal jacket that the American team refer to it as. So this was a patient who was failing to come off a ventilator and had severe tracheomalacia. And you can see that the trachea is collapsing inwards. There's a more than 60% reduction of the airway lumen with expiration. So we put a stent into that patient as a temporizing maneuver to get them off the ventilator, and then as they picked up and improved, we took the stent out. But it is a potential option. And of course, then the pulmonologists and critical care specialists may consider nasal nocturnal CPAP or NIV as an ongoing modality. This is just to show you we can do laser therapy. One of your colleagues just asked us to show a little picture of that. Again, we do it through a rigid bronchoscope, but I was saying to some of your colleagues a day or two ago, if you wanted to do it through, for example, a laryngeal mask, if you wanted to put laser onto something that was high in the trachea, then in order to minimize the risk of fire, you would fill the laryngeal mask not with air, but with water or saline. So, in other words, if there was any injury to the tube, that the water would put any fire hazard out. Fire is very rare, but you have to be very careful because it is a potential concern. We always do our procedures with a rigid bronchoplate, and we put the flexible bronchoscope through, and then we actually burn away. And this was somebody who had a stricture. We were talking the other day about intubation and the potential for post-intubation tracheal strictures. And this was one such patient. You can see the coronae at the distance. And one of the things that manager and the team and I were talking about was some of these are often in a spiral fashion, and you can appreciate that that seems to be going down like a spiral staircase. So we start at the top part and get rid of that, and then leave it, and then go further down. And we were also saying that there are other things you can do, but one thing to consider also is a drug called antimycin C. Now, so that was just the preamble, and I just wanted to finish just with a few slides. I know, I apologize that these slides contain a lot of information, but they are directly taken from that wonderful article that was published by the Difficult Airways Society in the United Kingdom about 8 years ago. I have a copy with me if anybody wants to make copies of it. Sadly, I was not an author of this. I mean, the other people know far more about it than me, and they were primarily a combination of ENT colleagues and anesthetic colleagues. But basically, the idea is that if you look at the overview is that you're doing a laryngoscopy and you succeed, then you would go on with a tracheal intubation. If you do a laryngoscopy and there's a failed intubation, then they would advocate a supraglottic airway device. And these have really come on for a lot of you, even who do ALS and ATLS. In the older days, people were taught about endotracheal intubation, but now, of course, we're looking at other maneuvers like iGel and so forth, very effectively. So you would look for a supraglottic airway device if you have failed intubation. Now, if you succeed, so you're okay now, things have stabilized and you succeed, then as one of my colleagues who gave a very good talk on Friday at the medical school, he was talking about bronchoscopy, and he said, you know, keep your eyes and ears open, which I think is very good advice. So stop and think. So should you now just wake the patient up, which is very, very reasonable? Should you intubate the trachea via the supraglottic airway device? Now, you might say, well, how can you do that? You can't get the device in. But there are some options. You could use a bougie. You could put a bougie, for example, through the supraglottic device into the trachea, take the device out, and then use the bougie that you know is in the trachea to get in your airway. Or you could proceed without intubating. You might say you've got a stable situation, the anesthetic team and the operating team just carry on. Or you may consider doing tracheostomy or crike. And usually it's cricothyroidotomy is what's preferred. So that would be if you succeed with your supraglottic airway device and you think, right, we've got time now, let's just slow down a little bit, let's think about where we're going to go, have a little talk maybe among yourselves, and see what you think is the best option. If you then fail with your supraglottic airway, then what do? You have a final attempt at face mask ventilation. If you succeed, the opinion is, right, we've got face mask ventilation, okay, we're doing okay, we're happy, we should just wake this patient up, because I think if we carry on, we're in a very difficult situation. So the advocacy is you wake the patient up. If, on the other hand, you fail face mask ventilation, then really you've got no option but to cricothyroidotomy. Now, one of the things that we do often in our hospital, but I stress it depends on people having local expertise, of course, and it is not part of the guidelines. One of the things we do often is we work closely with the anaesthetist. So if they would say to us, we've got a patient with a thyroid cancer, for example, who we think is a very difficult airway. So in theatre, we would be there with them and we would do a rigid bronchoscopy as part of this algorithm. But I stress that's not part of the published algorithm because a lot of centres around the world don't do that. But we have regularly worked with our ENT colleagues to be there at stand and to actually do a rigid bronchoscope. And indeed, sometimes we put a stent in at the time of surgical intervention. So that would be the first overview. Just giving you a few key features in Plan A, which is the first part. Obviously, your priority is maintenance of oxygenation. I mean, that is the priority. And you can see a few very important things. Importance of neuromuscular block, the role of video laryngoscopy, and that's really important for not just the anesthetic team, but pulmonologists and critical care specialists who are involved in the management of patients who have difficult airways. Because, of course, this patient may have a surgical intervention, and then you're now looking after this patient in intensive care, and if, God forbid, the airway is lost, what are you going to do? So these are the issues that are, I think, fairly well established. And the important thing is they give you a maximum of 3 attempts at laryngoscopy. So give it a good look. If you're not happy, then fine. And also to identify in advance. It may be that senior people like you should be involved. Don't leave it to someone junior if you predict that this is going to be a difficult airway. Now, so let's see if you've got an unanticipated. So the first one, you're kind of going in, I think, as the movie says, with your eyes wide open. But say you're going in and all of a sudden something happens and you think, my goodness, this is more difficult than we imagined. And I'm not talking about trauma, just you can't see the airway, you do not get a good view. So, Plan A, fairly simple. We've gone through this before. Optimize head and neck position, pre-oxygenate with adequate neuromuscular blockade. And with that, you succeed and you confirm tracheal intubation with capnography. And all of you are very familiar with capnography. It's a very standard monitoring process. And all of you, of course, will be competent in things like ALS and ATLS, where you're looking at end-tidal CO2. Okay, so if you declare a failed intubation, so you've gone at Plan A and you failed to get tracheal intubation, so that's a difficult airway, but you're not really anticipating that, what do you do next? Okay, well, maintaining oxygen, that's, of course, the priority. So we insert a supraglottic airway device, 2nd generation device recommended, change device size, 3 attempts for that, keep oxygenating and ventilating. If you succeed, again, just like the first part of the overview, stop and think, take a breath. I was saying to some of our colleagues that we like to use the phraseology that was in the very first Gladiator movie where they're invading Germania and the troops with Russell Crowe are coming around the back on horseback to attack from behind in the forest. And they say, whatever you do, hold the line. You are very skilled, experienced people, privileged to attend such a wonderful conference and pick up tips. But if people see you panicking, then the whole ship will sink. So hold the line, keep your cool. Think about the principles. Okay, we have succeeded. We're now going to stop and think. Should we wake the patient up because we didn't anticipate this? This could be a problem. Should we intubate the trachea with the supraglottic airway device? Again, you'll talk among yourselves. Should you proceed without intubating the trachea? That's always a very important thing to decide because, a lot of people will say, well, we haven't intubated the trachea. Of course, we have a supraglottic airway device, but by definition, we do not have a definitive airway. So a lot of people might be a bit anxious of carrying on without a formal tracheal intubation. But you will decide that among yourselves. Should you go for a front of neck tracheostomy or thyroidotomy? If you then fail with your supraglottic airway ventilation, you declare we're failing, we're not getting in. This is happening quickly. Okay, let's try face mask ventilation. Not possible. Okay, let's paralyze. Try a final attempt at face mask ventilation. 2-person technique, all jumps. You succeed. At that stage, wake the patient up. There's a great line in Shakespeare in King Henry IV where Falstaff says, discretion is the better part of valor. You pick your fight and there's no point in fighting on here. Okay, wake the patient up. If, on the other hand, you've got a failed SAD ventilation, at that point, you immediately say, right, we've got to go for front of the neck. And then you make that decision. So again, that's just a summary of what we had said. B relating to supraglottic airway device. So that's just a little summary of what we said. And this is just a summary of plan C, but we've got that on the first two tables. But the basic premise is that you maintain oxygenation, you escalate quickly through, you do not panic, you talk to people, but your fundamental principle is to oxygenate the patient. And declare failure, right? We've tried, okay, that hasn't worked. Tried, no, that hasn't worked. We've tried, that hasn't worked. Okay, we've tried, okay, front of neck. We've rapidly spiraled through. Don't delay, and make sure that you've got, like everything, you've got a team leader. It's really important that people can speak up if they see a problem. Absolutely, and that has to be encouraged. But equally so, once you have identified the problem and you're dealing with it, the last thing you need is what I call cerebral fibrillation. You've got loads of brain electrical activity, but no constructive output. And that's not helpful. You stick to the algorithms, it may be that we've missed something, then somebody will say, oh, look, you haven't noticed this. Absolutely, they should speak up and share that. But once you're together, you're rowing together, you've got a plan, stick with the plan. So the front of neck, I'm sure you're very familiar with this, but we feel the thyroid cartilage and the cricoid cartilage, and we go for the space in between. When we're doing a percutaneous tracheostomy, as you know, we go thyroid, cricoid, and then we go below. But in this situation, we're going the space between it. People call it the laryngeal shake. And again, this is taken directly from the excellent publication of the Difficult Airway Society. And when we go through, well, you'll see, I'll show you the technique in a minute, but that just shows you the actual positioning. And we often just do it on ourselves. You know, we ask our trainees to do it so they can feel. One of the things we often do in intensive care when we're doing these, if it's a difficult situation, is do it with the rigid bronchoscope place, which can really push everything up, and it's a nice big light from inside showing you where the landing zone will be for your device. But that would be the approach, the front of neck. And just to show you graphically, this is how we do it. So just to really correct our judgment technique, the membrane is palpable. This scalpel technique, you stab, twist, put in a bougie, and then put in a tube. There is that mechanism, but there is also a Seldinger type mechanism for doing this as well. So that there is a device where you put in a needle, you make a little incision, put in a needle, then put a guide wire in, and then railroad over the actual guide, and then put your tracheostomy well. Obviously, you can't confirm that with a bronchoscope because you won't be able to see the airway. This is a rapid procedure. More and more people now internationally are favoring this approach where you put a scalpel straight into the membrane and where you actually twist and then put in a bougie. So scalpel in, twist it, put your bougie straight in, and then put your tube. So that would be the kind of thing. And it's really important if you're going to do this. You know, you call for help, you give the patient 100% oxygen, you declare it. The key thing, I mean, one of your colleagues and a number of your colleagues at this conference has said, you know, make sure that people are giving direction. It doesn't matter who the captain of the ship is, but there has to be a captain of a ship. When we're teaching CAPITS, which is cardiac advanced life support, there are 6 key people, and when they come in, everyone has a lanyard in the intensive care with a number. And number 4 is the team leader. That person says, I am the leader, not because they're arrogant, but you listen to that person. You rally to that flag. But you declare you're going to do this. So this is, again, just a summary. Scalpel, they advocate a 10 blade, then put in a bougie, and the cuffed tube, 6 millimeters diameter is the approach. So I told you I would finish, well, within a lot of time. But I just wanted to make it clear, this is an excellent article if you get a chance to look at it. But basically, you all know this very, very well. It's just like all of these algorithms, whether it's ALS or ATLS or CALS or CRISP, But whatever you do, it's just sticking that together and not wasting time. If you go to A and it doesn't work, no problem, go to B. If that doesn't work, no problem, go to C. If that doesn't work, go to D. But don't fiddle around, just make your decision and go. And the other thing is have really good communication among your team. And obviously always defer to the man or woman who has the best expertise. Let he or she do the procedure if they've done loads of things. So I'd like to thank you very much for your attention, and if there are any questions, feel free to do so. As I said, I have one copy of this article, and I'm very happy to give it out for people to photocopy if they want, but I can give you the reference so you can get it online as well. But it was the Difficult Airway Society paper, and it was published, I think, in 2015 or 2016 in the United Kingdom. Thank you.
Thank you, sir. Since we are running late, we'll be moving on to the next topic.
Thank you, Dr. Thank you, Dr. Brandon Madden. And thank you, Dr. Harendra Thakur and Dr. Anish Joshi, sir, for your time. Moving on to our next session, that is a panel discussion on antibiotics resistance era and how to deal with it. I would like to call on stage panelists, Dr. Manoj Singh, Dr. Chaitri Shah, Dr. Sankalp Banjara, sorry, I apologize, Dr. Bhagesh Shah, Dr. Raviraj Singh Gohil, Dr. Darshan Shukla, Dr. Bhavini Shah, and Dr. Pradeep Bhattacharya as the moderator. I would also like to make an announcement. We have amongst us Dr. Bipin Patel. Sir is the GMC observer for our conference, GUJCRITICON 2024. Big round of applause. He is currently working as blood bank in charge of Sterling Hospital, Ahmedabad. He is the AMA Joint Secretary and Assessor in NABL and NABH. Again, big round of applause for Sir.
Thank you. Again, good morning. So, this is the second panel discussion, antibiotic resistance era, how to deal with. And I have a panel of Dr. Manoj Singh, yes, Dr. Raviraj Gohil, yes, Dr. Darshan Shukla, yes, Dr. Bhavani Shah, ये स्पेलिंग गलत है क्या? अच्छा अच्छा भाग्येश संकल्प नहीं संकल्प and Dr. Chaitri. Yeah. So a very good morning to all of you. Let us start. With antimicrobial resistance is one of the top global public health and development threats, and it is estimated that bacterial antimicrobial resistance was directly responsible for 1.27 million global deaths in 2019 and contributed to about 4.95 million deaths across the world. The misuse and overuse of antimicrobials in human, animals, and plants are the main drivers in this the development of drug-resistant pathogens. So AMR affects countries in all regions and at all income levels. Its drivers and consequences are exacerbated by poverty, inequality. Low and middle income countries are most affected. Obviously, I don't see that is less in developed countries. And antimicrobial resistance puts many of the gains of modern medicine at risk and makes infections harder to treat and makes other medical procedures and treatments such as surgery, cesarean, cancer, chemotherapy much riskier. So anyway, so is it really a big global concern? I have expressed the way it is going on. Dr. Manoj, yes, I need your special thought on this.
So it's, as you said, it is definitely a global concern. The earlier healthcare authorities and the global leaders understand this. We will be at ease in future when we fall sick. So reasons are many, as you said. To add on to what you said, our healthcare practices also needs to be checked the way we are doing in terms of being in attached to the hospital, the intensive care unit, the way we use our antibiotics, the way we see a non-infective or tropical patient and have a thin line, we see a trauma patient and not use an antibiotic. So the way we practice also is a global concern. With your leadership, this should be addressed in coming times. The second thing is unchecked population, unchecked sanitary issues, and unchecked cleanliness and hygiene in general things which we eat are increasing the resistance pattern even in healthy adults. So that's definitely a global concern.
Thank you. I think we have 45 minutes. How much time we have? So, misuse of antibiotic is one of the major concerns. Why we are developing antimicrobial resistance? So, Dr. Raviraj, will you say something about the misuse of antibiotic? What is your opinion?
Good morning, everyone. See, as Dr. Manoj Singh sir said, the antibiotic, this antimicrobial resistance is an emergency, right? So whenever in like CPR, we are using the life-saving drug adrenaline. Same in sepsis, the life-saving drug is antibiotic. So if we are not using responsibly use of antibiotic, it may lead to the very resistance bacteria and difficult to treat. So lots of concern about this irresponsible use of antibiotic usage. Like if we are using misuse in each and every right now, this is flu or some viral condition, immediately we are taking the medication over the counter. So many antibiotic available like this clarithromycin or azithromycin. Self medication most of the time because of lack of awareness of about this viral illness. No antibiotic will work in viral. Still, over the counter azithromycin and clarithromycin are available.
So, what do you think as a doctor, peer pressure for from the hospital administration, and secondly, peer pressure from the pharmaceutical industries?
Because it is always, see, it is not always this fault of any physician or any doctor. You always remember that the responsible usage. So we have to be use this proper prescribing this capacity. So second thing, overuse. That's because of the unnecessary we are prescribing and in low dose. Underuse is also underdosage is also a very much important concern in the resistance. And if we see there is a no many new antibiotics available in the pipeline. Okay. So see, still is there is all antibiotic is coming, but still the what is the role of that in newer the sepsis? But it's still question.
So there are many reasons: overprescribing, unnecessary use, incomplete courses, agriculture use. This is poor infection control, lack of new antibiotics, self-medication. So now, Doctor,
Can I add?
Yeah,
Can I
yeah,
add here?
yeah.
So you asked one very specific question to him.
Yeah, that is
the
why.
pressure of a hospital admin.
Yeah.
I'm sure, see, no one compelled us to become a doctor. So no one can compel you to write an antibiotic to justify your salary. That is what you meant.
No,
So admin will never tell you to prescribe antibiotic, justify long antibiotics. Yes, if you have a good infection control department, they might oversee what's happening. If you have a stewardship program, then they might see it, but they will not tell you to write an antibiotic just because.
No, it was directed to another side basically.
Okay.
Whether you have an antibiotic policy in your hospital or not.
Make it in India, as you know, not even in the government or the public sector.
Yeah.
So making an antibiotic policy is like a self-discipline. As the points I think you should read out loud for few students.
Yeah.
So that will actually stress what you
No,
want.
these are important. Over-prescribing, unnecessary use, incomplete courses, agriculture use, poor infection control, lack of new antibiotics, self-medication. Obviously, you don't get best by anybody, but best is to have your own antibiotic protocol. Algorithm for your ICU should have your own protocol. Is better. So,
One point I want to add, so you rightly mentioned this agricultural use. So that is see, globally, if we see only 30% of antibiotic we are using for the human this disease, but 70 to 80% we are using for the animal agriculture. So that is very main concern for that. And still see tetracyclines in ionophore. They are main drug we are using for the animal agriculture.
so my next question, Dr. Darshan Shukla, how much contribution comes from environmental lack of access of clean water, sanitation? Do you have any comment? The mass movement of people which happen now, it is very common. We see the kind of war which is going on across the world, climate change and biodiversity loss. All these things are major responsible factor, don't you think? That antimicrobial resistance is.
It's 100% contributing, but that is my time. If sudden changes are there, that cannot lead to resistance. Gradually, day by day, it decreases resistance. As we see, in previous time, we were very close to all animals, cows and all were there at our home, sheep, cow. Now, we don't allow our children to be close to street animals or dust. So now we are seeing the more and more resistant organisms due to this environmental changes and our daily life implications. But these changes are.
So you feel that these are important factors?
100%.
100% important factors. Gives rise to more and more of antimicrobial resistance. Now, Dr. Shah, for you, this question is, what is the present situation about drug resistance in bacteria? What do you feel? Bacteria, fungi, parasites, these are important. What about bacteria?
So, sir, when we get to the bottom line of it, then why did this resistance happen? So it is basically the reaction of the bug towards the human behavior. Whether it was the pori channels, whether it was antimicrobial stewardship, whether it was different kinds of ways of handling drugs, it was our misuse, abuse in different aspects of life that led the bug to react in a fashion which was from when? 2004, I think. I took my first talk on antibiotic stewardship in around 2004-5. Till then, we were calling it the silent pandemic. Today, it's not the silent pandemic. It's making a lot of noise, and therefore, I think all of us stakeholders are sitting. So, antibiotic resistance is here to stay. That is for sure. A single cell bacteria, because I think I would be the only microbiologist sitting here in the forum. So a single cell bacteria seems to be brilliant than the multicellular organisms that we all are. So it is here to stay. But now that the pandemic is no longer silent. The world is awake. The world has to handle this because this is affecting both. It is affecting life. It is affecting economics. It is affecting the whole world economy. So WHO actually has come up with a lot of suggestions. The first actually for everybody to read also, it's a beautiful document that has come out, which is the Global Antimicrobial Resistance Surveillance System that is there, GLASS which is called. It has very beautifully defined, I think it was, the inception was in 2015 and the 2022 was the 5th report that came out, which has 76 countries.
Does India contribute to that?
Yes. But what happens is
2015, India's contribution was not there.
not there. Now, in the 2022. But what is happening is that they have given a brilliant chart which says the bug, the site, the number, the gender, the area. So, I think they have the liberty of putting in whatever they have as data. So everybody does not contribute 100% to whatever GLASS has put forward. And therefore, even the median data that they give out is not like 100%. So as of now, if we see that there is at least 42% resistance to third generation cephalosporins in E. coli and 35% MRSA across the globe. Even urine, 20% resistance to the normal second line drugs that we use or we plan to use, that is 1 in 5, so would be almost 20%. So GLASS has it, and even the last, as we talk about the economy, as I rightly said, they are also worried now because of resistance. It is affecting everything. And because I'm a microbiologist and whatever quorum I have here, technology in microbiology has also been one of the reasons for antimicrobial resistance. Still sticking on to the disk diffusion method when you have an MIC available since 2000. So asking for the right test to combat these bugs and tell them that we are equally smart is more important.
Thank you. So, most important is projection by the Organization for Economic Cooperation and Development indicate an anticipated twofold surge in the resistance to last resort of antibiotic 2000 by 2035. So it is going to be huge what is expected in 2050. So drug resistance in fungi. Dr. Bhagesh, you have to take this because Dr. Sankalp is not there. What about fungi? Because that is also in intensive care, it has now very well known to all of us that they are another major contributors after bacteria.
Thank you, sir. First of all, as we are discussing antimicrobial resistance in this panel discussion, sometimes we have heard in a lighter way that this is to threaten new generation, this is to awake new generation, but it is old and new and everything going on, and it has gone up to the level where in this panel we are discussing fungi right now. So if you ask me about fungi, recently we had a patient who had a multiple catheterization issue, and the fungi came as positive, Candida auris. So it is very much there, and lot of issues as we have discussed in antibiotics. Same goes for antifungal also, the wrong choice, wrong dose, wrong duration, and wrong site sometimes, where we have not chosen the right one. So all this has contributed to resistance in fungi also, and it has caused a major issue to the level where World Health Organization and other global societies have been discussing about fungal resistance also.
Yes, it is becoming a major concern, and we all know this Candida auris creating a problem. We get so many Candida auris nowadays, extend our cultures to the microbiology. So, yes.
You have a microbiologist sitting here.
Yes.
So you don't get an opportunity so often. Again, the root cause, sir, when we are talking about Candida and stewardship for antifungals, very, very important that we cannot treat a candida species. If you are having a report of a candida species, it is very, very important to call on to the labs and tell them, I want the species. Because your drug, your therapy would be indicative of the species that is actually. Your clinical management will change with the species. So identifying the right species, treating candida species should not be the norm.
Correct. So, Dr. Chaitri, what is the present situation? Drug resistance in HIV, tuberculosis, malaria, because these are now common bugs in our ICU. Immunocompromised patients are there, we get tropical diseases, tuberculosis is very common in ICU patients. These are common things. What is the present situation?
So like other bugs and other the species. Regarding HIV, the resistance is related to the mutation in the virus. And because of that, there is a development of drug resistance because action will not be there to prevent the replication of the virus. And this can be detected at the time of when the person is either acquiring the illness or ongoing treatment. And the other thing which contributes is drug-drug interaction with the ART treatment. So again, like Madam said, surveillance is required, stewardship to detect and the burden at present globally. That is the urgent situation to comment upon what is the present situation and which is already started. Regarding tuberculosis, sir, the multi-drug resistance tuberculosis since years. And I'm also in a trust hospital and a medical college. And day in, day out, I've seen this patient. And we have very good collection of data and where the resistance and especially our spine surgeon, Dr. Prabhakar, which is renowned spine surgeon, and we are getting lots many cases of cox spine and multi-drug resistance. Multi-drug resistance in tuberculosis when we label either there is a resistance to isoniazid and rifampicin or both. So in that case, second line of treatment will start. Now the problem with second line of treatment is again those treatment is costly. Many of the time second line is overuse or misuse by the practitioner or by some of the time it's we know our problem with the general practitioner also. So that also is acquired or contributing in multi-drug second line resistance. And third, we have to strategically diagnose and treatment contribution of second line. Otherwise, there will be the situation will be worse even with the second line. So that is the concern. The third one is the malaria. So we know that chloroquine resistance era in 90s has gone. And now the era has come where ACT is also contributing to resistance, especially some of the countries of eastern side and African countries where the resistance is high with the malaria. And this is also one of, because again the contributing factor in this is overuse and misuse. Still the general practitioner, there is one methodology. Fever with chills and rigors, we use Kodego, anti-malarial Dego. So that is the contributing thing.
So more in clinical use.
Clinical.
So that is the contributing factors. Because yes, artisanal resistance is now become common. So these are the details who are not already been discussed. Now to Dr. Manoj, in neglected tropical disease, this is another thing which, because all these are Indian problems. Yeah, if I say very specific to our country, neglected tropical diseases. What is the present situation? Neglected tropical diseases.
First of all, I should have read this. Today only I read about it. Yeah. Neglected this. Which were very prevalent in India. So I take your permission to read out the classification. So neglected tropical diseases are clubbed by helminthic infections, protozoal infections, some fungi like mycetoma, bacteria like Borrelia ulcer, leprosy, which all we know, and trachoma. So this, the WHO Sustainable Goals, as they defined in a recent article, they would like to end this in African and Asian countries by 2030 because they have been amenable to treatment. But your question is very, very specific. The resistance pattern, we have to say, in most of them, slowly resistance have started to creep in. Like Kala-azar, leprosy, and some of the helminthic infection.
Helminthic, yes.
So, helminthic infection, like how we have been advised to give ivermectin and albendazole blindly without even diagnosis. So, be very aware of that when the resistance is there. At least diagnostic modalities, if your application say is to be very prompt. Don't treat any diarrheal or tropical disease bluntly with or blankly with combination of azithromycin and albendazole because resistance is there. And it's
The way ivermectin has been used in COVID.
yes, it's less rapidly misused in COVID.
Yes.
Can I add on that? How do we address the diagnostic things for this? What are the current strategies?
The strategies, of course, you have your PCRs that are available. But diagnostics, again, I think there will be a time when we'll be talking about stewardship in diagnostics also. Because there are populations who use it so rampantly and there are populations who don't use it at all. So wisely using diagnostics in the right way. Because as he rightly said, we are seeing huge increase in MICs and NTMs in a very short span. NTM has crossed MTB also, in like albicans versus non-albicans. This is the scenario with MTB and NTMs now. And when we are reporting NTMs, MICs of NTMs, rapid growers, we are seeing gradual increase in MICs, and I think it will be difficult, like even salmonella GC. You are seeing resistance in septoid zones. So we were discussing in one of our infectious disease talks that we would have patients who would die of typhoid in the next decade, which is a very sorry situation.
In last year we found Baroda is resistant to price. So it is very important to how to treat that resistance, this entry. So we should use the azithromycin twice a day for 14 to 21 days to eradicate this. So we should know that how to treat this complicated typhoid or resistance typhoid. It is very important.
Correct. She is actually, we've done that project, that whole Baroda thing. We did, I was a PI in that project. So we did it with CMC. It was a national project. A new CTX M15. I mean, it is encoding the plasmid. We did the whole sequencing of the salmonella, all the species. And you're right, the pocket is in Baroda also right now, a big pocket. And we did almost 150 strains. And all of them are coming up with this new mutant on the gene, which will be very difficult to treat.
Yeah, sir. So I think awareness is very important. If we are aware, we'll find out a way. If we are not aware and we allow the things to happen, then the future is dark. So that is the most important thing. Now this is one most important thing which Dr. H has come up. One health approach. Can you highlight on this, Dr. H?
I think it is not a newer one. See, it is, I think if we see that, I think since 2003-4, it is a Wildlife Conservation Society developed this approach, and that is taken over by it is succeeding by the WHO.
So what is the current status? Although it has been started, what is the current status?
So I think it is one of the globally unified one approach, and that includes all the systems, not only human. But we have to include the human as well as animal, as well as all the ecosystem, like this agricultural and animal agriculture. That's why see, it is animal is a very complex problem. It is not a one-man job. We have to require all the help of the stakeholder, like healthcare providers, or doctors, or even people. We have to aware the people about this resistance.
So whenever do you feel that whenever we do such kind of meeting, we should call people from agricultural discipline, we should call people from veterinary disciplines, and we should do a combined meeting.
Definitely.
That will help.
Yes, government and policy maker must be there.
And policy.
Yes,
policy
maker. That is very important. We know everything about resistance, how to use antibiotics and everything. But for public awareness, and secondly, to guideline makers or policy makers, it should be there. Secondly, pharmaceutical and agricultural company person, responsible person should be there for that meeting. Otherwise, it will not cover that part, right? So it is a globally unified approach.
So whenever we do such kind of this antimicrobial resistance discussion, because now we are going towards this One Health approach, we must have few representatives from agriculture side as well as veterinary side. This is very important. And that is how after that it came Global Action Plan on Antimicrobial Resistance. Dr.
Yes, sir. I think in 2015, when our JP Nadda sir was the health minister, at that time in 68 or 67 World Health Assembly, he went as the leader. And at that time, this issue was coined, and the whole world had to be united for the same. And in 2022, World Health approach was actually implemented by the Food and Agriculture Division of UN. So, but that should be percolated to each and every country equally as per their microbiota. But I don't know that how the government has implemented till date now. As we went there in 2015, till date, we have not seen any
any change or any
action.
improvement or
Yes.
any progress in that.
Government is saying since last 10 years, but no any progress we have seen in this kind of action.
Yeah, so our job basically remains is that how we can think at local level about these things. Because global antimicrobial action plan. Yes.
Our contribution.
Yeah.
And since I told that I'm from medical college, and since last 1 year, I've started classes for postgraduate students, irrespective of their specialty, in collaboration with microbiology department, how to implement or that will be strategically stewardship program. Second, last week was antimicrobial resistance awareness week. So it was totally I designed by the students. Postgraduate presented the case studies. Second day debate that was by the postgraduate student. Third day panel discussion that was by student. And last, because the field visit, if anyone is from medical college, they know that the first MBBS students are given family adaptation program. So undergraduate participated at ground level in village for this antibiotic resistance. They displayed poster, they presented a skit. So the national action plan is there, even it is with NMC. But implementation, again the resistance is from stockholder.
One thing has to start from the bottom line. We need to include this agriculture, operation, animal health.
So it is started.
Yeah.
Still, implementation is by enforcement.
One thing, sir, we see, Madam had said from medical college and all, we are implementing. We are teaching to our registrar and everyone. But what about the policy from government as in rural area or periphery? Practitioners are not from allopathy. They are homeopathy, Ayurvedic, even BSc nursing.
That is another.
BSc the government is allowing BSc nursing to prescribe antibiotic officially.
That is beyond the scope of this discussion. I think if we go to that, it will be another one. So active aware, this is another very important thing. Shah will answer this. Aware program, WHO, again, antimicrobial stewardship and everything. And we have already have started doing this now. We have got very good results.
Actually, sir, I am antique now. I feel in this, forever I've been talking about stewardship. And I mean, all the local clinicians who are here, they know, I mean, they don't like me much because I am quite outspoken on that factor. That who writes the drugs, sir? Who writes it? And who doesn't know what is right and what is wrong? Everybody knows it. So it's time to be the change ourselves, what we want to see in this world. So that is primarily the take home that we have to change. And antibiotic stewardship program is brilliantly written all over the book. The core 5 elements are brilliantly written everywhere. Everybody can read it. The point comes in what is our take to implement that. As you rightly mentioned, the AWARE program. If you see the spelling, it is to assess the antibiotics, yeah, access them, watch them, then to reserve them. So they have brilliantly classified all different classes of antibiotics, all how it should be given, and they have written about all the diseases. It's a beautiful table that they have written. Even if we blindly follow it, sir, it can give very good results. Very well classified, and a printout can be taken and put in all OPDs also, because you just have to see what they have written and what you want to give. Because the clinicians always, and they are very right, that sitting in a microbiology lab, we don't face relatives or we don't face the patients or we don't talk to them, but they have to do that job which is not very pleasant. And so they have to, kind of use antibiotics at times. But this is...
We are left with 1 minute, madam. We'll go to last couple of questions. How we can increase surveillance of antimicrobial resistance and antimicrobial consumption in our country?
I'll
Just
short.
two, three slides.
One thing for surveillance, definitely it is sharing and gathering the data in real time, as well as using the right test, as rightly Madam has said previously. And for consumption, we all have discussed how we are misusing all this consumption. But again, consumption takes credit from many areas. So one is the user or the prescriber, second is the policymaker, third is the pharma industry or the production side, fourth is the public. There also we need awareness. So it is all together, all stakeholders coming into picture so that the consumption can be controlled in a positive way.
Last question. Pharmaceutical industries in India, their contribution in increased antimicrobial resistance.
Be very fast and precise. Only 3 comments from my side.
Yeah.
One is the wastage, water wastage. Still, we don't have the strict legal, and in India, if nothing is enforced by law, then there will be nothing ethical or nothing awareness or nothing one-sided. So that has to be one solution. And there are 2 other points. One is the irrational combination of drugs. So that has to be, so control again, that will be needed. And third, no one can deny the pressure prescription, and that is incentive based. So that also we need to control.
One of the major contributors.
This one line, very surprisingly.
For farmer industry role, I will just say one line. We are having a small town in periphery, only 20,000 population. We got organ phosphorus poisoning patient from there. He was getting serious sector. So, in that 20,000 population town, that pharmaceutical company has penetrated to compulsory to prescribe serious sector. And he was not knowing, that guy was not knowing when to use, how to use. This is the best drug.
Yeah, that is the biggest. Anyway, we have finished with our time. So to conclude, I think the what this is an antibiotic pipeline access crisis. We all know this is a big problem, and in addition to health, death, and disability, AMR is going to cost $trillions across the world. So if we're not aware now, I think future is dark. So priorities to address antimicrobial resistance in human health that include preventing all infection, universal access to quality diagnosis, that is very important, although it is increasing, appropriate treatment of infection and strategic information and innovation. Awareness program is very, very important, and we must teach our juniors, and we must promote this thing across our, along with not only intensive, because we understand, because I know that other discipline, if you talk to cardiologists, they don't know anything. If you talk to nephrologists, they do not know. They just know kidney, how to adjust the dose in kidney, that's all. But if you ask about resistance, they do not have any awareness. And so that is a big problem. So I think with that, I thank all the panelists and thank you all for quite listening. Thank you very much.
Thank you, Dr. Pradeep Bhattacharya, for a wonderful discussion on antibiotic resistance. Thank you to all the panelists. I would like to call on stage our international faculty, Dr. Jenny Cardenas. I would also like to call on stage Dr. Bipin Patel, our GMC observer for the conference. Dr. Gopal Raval, organizing chairperson of this conference, will facilitate. Huge round of applause, please. Well, thank you very much one more time for inviting me to this excellent conference. I'm having a very good time sharing with all of you. Now, I'm talking about the effective thromboprophylaxis in the ICU. I do not have any conflict of interest different than to show you the best and most updated evidence in management of critical ill patients. The objective for this lecture is that to establish the importance of doing the daily exercise to assess the risk and indicate thromboprophylaxis in our patient and to know the challenging scenarios in hospitalized ICU patients. The agenda is to know the magnitude of the problem, risk assessment, effective thromboprophylaxis, extended thromboprophylaxis, the challenges in the daily clinical practice, and the conclusions. Talking about the magnitude of the problem, as we all know, all of the thromboembolic disease affects more than 10 million people each year, and it contributes substantially to the global burden of disease. The thromboprophylaxis, that they are two very good different groups that they are doing that the best in this patient, that they are orthopedic and cancer surgery. But as you all know, the majority of them is more than 30% of the patient. The risk factor we cannot find it, and it is the thromboembolic disease is not provoked. And the other is major surgery, and the cancer patient, they have a more most of them. Annual incidence is 1 to 2 cases per 1,000 population. It is increased with age, 4 times higher in developed countries. That could be because they are like looking for this, they are finding or trying to do more evaluation, assessment, risk, and women between 20 to 40 years old. It is the third most common cardiovascular disorder after the stroke and after the myocardial infarction. It is estimated the US mortality between 100,000 and 180,000 per year. In the field of cancer, there is different incidence. In the case of the gallbladder and sinus is 3%, colon and prostate is 4 to 7%, lung, stomach, ovary, and brain 10 to 24%, and in the case of pancreas cancer is 15%. So the thromboembolic disease is related with, of course, a death, major bleeding, and long-term disability. The annual cost between they are between 1.5 to 3.3 billion in Europe and 7 to 10 billion dollars in the US. The pulmonary embolism-related death have decreased because of this exercise to doing more thromboprophylaxis, and 20% die within the first year of diagnosis. There is a significant reduction in quality of life with the patient who can experience the thromboembolic disease. 50% is alteration in physical condition, and 3% of them are develop chronic hypertension, pulmonary hypertension. The incidence in critical ill patients is around 13 to 30%. There are a very huge gap, and this is because of the different strategies to find the thromboprophylaxis failure. Even if we are doing a very good exercise to assess the risk, and even if we put the patient in thromboprophylaxis, there is a percentage that can be failure. It is in between 5 to 15.5%. And that is why we need to talk more about the thromboprophylaxis in the ICU, because all of these patients are in high risk. And still, the incidence is really different. For example, in Tehran is 3.5, in Thailand 3.6, and in patients with sepsis and septic shock, the incidence could increase in order to around 37.2%. And the sepsis and septic shock, this is the incidence. 25% of the pulmonary embolism result in the sudden death, and that's the case that the patient can die at home. 50% of DVTs will have long-term complications that lead to disability, and 1 of 3 people with thromboembolic disease will have recurrence in the next 10 years. So at the ICU, at the bedside, what should we do? We are always in this tricky problem, because in one hand we have the thrombocytes and in the other the bleeding. So why it is important to talk about thromboprophylaxis in critical ill patients? Because it's the main cause of preventable morbidity and mortality in our patients. It's the main cause, it's the number 1. So the prevention of thromboembolic disease nowadays is a critical patient safety measure, and in the ICU an institutional key performance indicator. It's not just about talking about the critical ill patient, it's talking about the quality of care in the hospitals. So we should assess the risk. Remember that, for example, moderate to high risk of thromboembolic disease in medical patients is around 42%, and in surgical patients 64%. And we all know some of the specific high risk factors like previous thromboembolic disease, immobility, peripheral catheter, cancer, and the number of red blood cells transfused. That's why the Joint Commission International make that the presence of DVT or PE is a serious event and requires reporting in these different high-quality hospitals. And the risk factors could be genetic, like in the case of thrombophilias, environmental, acquired, in patients with elderly, cancer, immobility, trauma, surgery, hospitalization, and other like chronic illness and women of reproductive age. Another risk factor, of course, the thrombophilic condition that we all need to be sure that the patient is probably has or not one of them, and in the other is the general risk factor like for BTE, age, past history of thromboembolic disease, cancer, hymobilization, obesity, pregnancy, and related to the ICU, specific are the sepsis, the use of vasopressor, respiratory or cardiac failure, pharmacological sedation, mechanical ventilation, central venous catheter, and the end stage of renal failure. That's why the NICE guideline published in 2018, but a review that they did in 2021, they put the access to risk the bleeding and thrombosis for all of the patients. In medical patients, they recommend to do on admission to the hospital by electronic tool and to offer pharmacological or mechanical thromboprophylaxis if the patient depends of the hand of the patient. And start within the first 14 hours. Look at here, 14 hours, we need to start the thromboprophylaxis in our patients. It's not 1, 2, or 3 days after they get into the ICU. And in surgical patients, it will be individualized with the surgical team because they need to, we need to know how was the bleeding during the procedure and how was all of the others. The time is okay. When the patient came to the ICU, we need to evaluate to consider the high bleeding risk or to have contraindication for anticoagulation. If the patient doesn't have any contraindication, we should put the patient in pharmacologic prophylaxis. If the patient has some of the contraindication, we should do mechanical prophylaxis, like intermittent pneumatic compression and gradual compression stocking. If the bleeding risk decreases in this group of the patient, we should think every single day to put in pharmacological prophylaxis. And that's another good thing is that the Institute for Healthcare Improvement, in order to save 5 million lives, they give us some recommendations to prevent the pneumonia the ventilator-associated pneumonia, and one of them is to do the deep venous thrombosis prophylaxis in all of the patients that they came to the ICU. Look at this study, they published on chest more than 10 years ago, but still very good because they say that the omission of early thromboprophylaxis, skipping this thromboprophylaxis within the first 24 hours of ICU admission for no obvious reason is associated with higher ICU mortality. So we all have in our hands the way to improve the mortality in our patients. And still, we need to know the risk measure scales in order to evaluate in the patient-centered care to evaluate the risk of the bleeding versus the thrombosis. So how can we measure? Well, we use Hasbulet to measure the risk of the bleeding. And in surgical patients, 1 minute? To 1 minute, yes? Yeah. 2 minutes, okay. So, and I wanted to show you all of the scales that we have in surgical patients. We use this Caprini score, in medical patients pathway score, in cancer patient the Coran score. And remember that all the patients with cancer, they are in high risk of thrombosis. If we have, this is a very nice study that they did in Australia. They compared in 2009 how many day omission of early thromboprophylaxis they did, and in that time it was 13%, and nowadays it's less than 5, it's like around 4%. And they said that it happened because there is a leadership, like a young leadership right now nowadays. That is just an epidemiologic study showing us that is still very high, all of the thrombosis in our patients. So we can go to probably some of the conclusions. Okay, challenge in daily clinical practice. The prevalence in ICU is underestimated. Frequently is silent. It's even in patients with sedation and mechanical ventilation. Difficult to diagnose and untreat this disease is associated with a mortality around 30%. So the conclusion is that first of all patients admitted to the hospital must have a risk assessment for thromboembolic disease. And the second, if there is no contraindication, all patients in ICU should receive thromboprophylaxis, mainly with low molecular weight heparins. Develop local policies and guidelines for evidence-based thromboprophylaxis. Update our guidelines. All patients in ICU are in high risk. Individualized thromboprophylaxis every single day. Start it as soon as possible. Daily review of thromboprophylaxis we should do it and monitor and evaluate compliance, give feedback, and involve all of the professionals. Thank you very much.
Thank you, ma'am. Such a nice lecture, and we know about venous thrombophlebitis. Any questions from audience? So thank you, ma'am, for nice lectures. Thank you. So now it's time for our inauguration ceremony of GUJCRITICON 2024. So I, one by one, today our chief guest is Dr. Mehul Shah. He is basically current president of Gujarat State Branch IMA, and he is council member of GMC. So we welcome sir on behalf of GUJCRITICON organizing committee. And one by one, I call all guests to come on the stage. Dr. Mehul Shah, please sir come on the stage. Dr. Tushar Patel, he is a past president of IMA and current organizing secretary of GUJCRITICON 2024. Then Dr. Professor Brendan, please come on the stage for our inauguration ceremony. Professor Brendan, please. Professor Jenny, please come on the stage for the inauguration ceremony of 2024. Dr. Pradeep Bhattacharya, sir, he is now president of our Indian Society of Critical Care Medicine. Please, sir, come on the stage. Dr. Srinivasan Samvedan, sir, he is president-elect, is upcoming president of our National Society Indian Critical Care. So please, sir, on the stage. Dr. Gopal Rawal, he is the organizing chairman of our GUJCRITICON 2024. Huge round of applause for these guys. Because of their efforts, this basically the program will be Dr. Mehul Shah. He is organizing secretary of GUJCRITICON 2024. Dr. Raj Rawal sir, he is basically scientific chairman of this whole program. We run since last 2 days. So Dr. Raj Rawal is the scientific chairman, and Dr. Amrish Patel. Without his efforts, this event couldn't make it. He is the treasurer of GUJCRITICON 2024 and current ISSCM Ahmedabad. So thank you. Welcome on behalf of GUJCRITICON 2024 organizing committee. So now I want to felicitate all our guests. So we first felicitate Dr. Mehul Shah sir. He is basically president of Gujarat State Branch IMA and council member of GMC. So we felicitate with bouquet by Dr. Tushar Patel. He will felicitate Dr. Tushar Mehul Shah sir. So please, huge round of applause for Dr. Mehul Shah to make a time to just for our ceremony. So thank you sir for being here, and huge round of applause. Please, તાળીઓ વગાડો, ચા ને બધું છે, પાછળ લંચ પણ છે એટલે અવાજ આવવો જોઈએ. So please, huge round of applause for him. Now next, we felicitate Dr. Professor Brendan by felicited by Dr. Gopal Rawal sir. So Dr. Gopal Rawal sir will felicitate Professor Brendan with bouquet. Thank you sir for your efforts, time to make a grand success of GUJCRITICON 2024. So thank you sir. Next, we felicitate Professor Jenny by Dr. Mehul Solanki. So, Professor Jenny will be felicited by Dr. Mehul Solanki. He is organizing secretary of GUJCRITICON 2024. So, thank you, sir. Now we felicitate Dr. Pradeep Bhattacharya, sir, by Dr. Amrish Patel. Dr. Amrish Patel, sir, will be felicited to the Dr. Pradeep Bhattacharya. He is the president of National Society of Indian Society of Critical Care Medicine, current president of our National Society. Thank you, sir. And now Dr. Srinivasan Samvedan is again future president of our society. So we felicited by Dr. Raj Rawal sir. So Raj Rawal sir will felicitate Dr. Srinivasan Samvedan. Thank you, sir, for your time and make a huge success of our GUJCRITICON 2024. So, as you know, this is Indian tradition. We always know the basically our Hindu culture and Indian culture. So we request to all the members on the dais to lamp lighting program by our. So please, all the dignitaries, please on near to the lamp and just we lamp lighting program and inaugurate our function of GUJCRITICON 2024. All guests, please. So huge round of applause for this left lighting program, please. આજે તાળીઓ રૂકવી ના જોઈએ. તે 2 દિવસની પછી આપણે ઊંઘવાનું છે, તો બધાને રિક્વેસ્ટ છે. So these are 10 dignitaries and 2 days of work. I think almost the 2 days, but we know, though, please. Now, time for our souvenir launching of GUJCRITICON 2024 with the efforts of Dr. Bhagesh and Dr. Mansi. Now we just inaugurate our souvenir by our all guests, and please come on the stage, Dr. Bhagesh and Dr. Mansi, wherever there. Without their effort, this souvenir would not make. So please come on the stage, Dr. Bhagesh and Dr. Mansi also on the stage. So please, souvenir will be hands-on to all the guests. Ravi, please. So we one by one do all souvenirs and we launch today. So just inaugurate our functions with the souvenir launching by all the guests, Dr. Mehul Shah, Professor Brendan, Professor Danny. So now we inaugurate. Huge round of applause for the souvenir launching of our GUJCRITICON 2024. So this is our souvenir with the great effort of our 2 dignitaries, being Dr. Bhagesh and Dr. Mansi Rannayak. Without their effort, this would not happen. So huge round of applause for those guys. And this is book launching, souvenir launching of GUJCRITICON 2024. So now time for our organizing chairman, Dr. Gopal Rawal sir will tell you few words about the stories and history of GUJCRITICON, how it evolved and all these things. So please come on the stage, Dr. Gopal Rawal sir, and tell us few words.
Respected Dr. Mehul Shah sir, President of IMA GSB, Professor Brandon, Professor Jenny, our beloved President Dr. Bhattacharya, and going to become a President of ISSCM, Dr. my friend Srinivas, and my team, Dr. Tushar Patel, Dr. Mehul Solanki, Amrish Patel, and my beloved Raj Rawal, the scientific chairman. And all thanks to my organizing team and my Gujarat ISSCM team also to make this conference a huge success. It was our dream how we can fulfill the successful conference, but all efforts come true. So just I will highlight about the GUJCRITICON that 2013 it was our friend's dream to start a conference in Gujarat, and that decision was made by our friends Manoj, Raj, and all of us to start, and which supported by our Gujarat city branch like Ritesh from Baroda, Dr. Chirag, Dr. Karamta from Rajkot, Anuj from Surat, and all other teams. So now we have a 6th ISSM branch in Gujarat, and we have started to spread the awareness of the critical among the Gujarat and nearby state also. So this is the 10th GUJCRITICON conference, and it's my privilege to welcome you. I have seen all conversation, connection, collaboration with our respected international, state and national faculties. The students are exchanging the knowledge and everything. And this time we have decided to enter our ISCCM in medical college. And we got a huge response from all 6 medical college of Ahmedabad. And I'm very much thankful to Dean and the Superintendent and all the specialty like medicine, respiratory medicine, anesthesia, and emergency medicine. They have given supports. And we have also done the nursing workshop because nursing are the backbone of our critical care. So huge success in nursing workshop, around 250 plus delegates they participate, and we have done the all kind of workshop like mechanical ventilation, hemodynamics, ultrasound, and this week is the antibiotic resistance awareness week. This is the we are lucky to during this week we have done the workshop. So that we have done at GMERS Sola, and with great effort of my friends Anuj, we have huge succeed in that workshop. And so thank you so much. And I'm not taking too much time. So again, like our traditions of Gujarati, that thank you so much. Thank you.
Thank you, sir. So now, today we have an opportunity to basically Dr. Pradeep Bhattacharya is the president of current National ISCCM. So please come on the stage and give us few words. Your inspiration would be great for us. So please, next Dr. Pradeep Bhattacharya.
Good morning again. All the dignitaries sitting on the dais, dignitaries sitting in front, all faculty members, delegates, all the organizers and supporters. First of all, thank you for giving me an opportunity to participate in this GUJCRITICON. And it has always been a pleasure for me to participate. This time I am participating here as a president of ISCCM. I'm coming here for, I think, many number of years. I think for last 7-8 years I am coming constantly to this conference. And every time I come, I see more enthusiasm amongst all the participants, delegates, faculties, and it is real pleasure to come to Gujarat, I tell you. I always feel very homely when I come here. And this time when Dr. Rawal asked me, I said immediately, okay, yes, I have to come, I'll come. Even if you do not say, I'll definitely. So anyway, first of all, huge congratulations for the success of this conference. But as a president, I have certain thoughts in my mind. I just want to express that critical care specialty in our country is developing. And this is high time that we should take some strong thought process in our mind. We need to go ahead. We have to go far ahead at what we are currently. So let us start a movement from here now. And what I wish, basically, I wish that every medical college should have a separate critical care department in the country. Secondly, I wish that every district hospital should have one basic critical care unit. Third, this is high time to prepare a proposal in which, with the help of the government, we can prepare more and more critical care interns. We need interns to work in periphery. So if we prepare interns that will differentiate between expert and those who are practicing basic critical care, who will be useful for our district and peripheral hospitals. Categorically, we need to differentiate between basic critical care unit and advanced critical care unit. Every advanced ICU in this country, which is run by trained critical care specialists, should be a closed ICU, should be a closed system. All patients getting admitted in advanced critical care should be admitted under the critical care expert. Every critical care department should run its own OPD to look after post-critical care patients. Don't allow others. So we have to understand that NMC has started DM in critical care, which means that it is a super specialty discipline rather than a subspecialty. We have to understand this. This is a super specialty discipline. We have to create our own identity in the community. For that, infiltration or interference of any kind, especially of other primary discipline, should be discouraged or not entertained. To create a public awareness, we have to conduct more and more programs with peripheral hospitals and medical colleges. We have to see how we can increase the interest of DM and DRMB students in our day-to-day society affairs. We have to involve them for all our affairs, and senior leadership should always consider how to appropriately prepare and promote the next generation, because that is what we are looking for in future. This is how we have to go in future, and that is how we can show our existence in future. So with that, I thank you all for inviting me. Thank you very much.
Thank you, sir. If this happens, this will be a blessing for critical care department especially. And we discussed so many times these things, so this will be made the future of our critical care medicines. Thank you, sir, for your kind words. Now, we have this GUJCRITICON 2 international faculties, and Professor Brendan, he is our basically inspiration. So he will share few experience about our GUJCRITICON and give us few words to the GUJCRITICON 2024. So I invite Professor Brendan to give few words about GUJCRITICON 2024. How's your experience during these days about the two organizing committee? Thank you, sir.
It's a privilege, as I said, to be here. I think that there are a number of words that come to mind. I think the first thing was the atmosphere. There was an absolutely lovely atmosphere here for the last few days, and I think that atmosphere was very conducive with learning. I thought all the speakers were excellent. I thought that from the top down, there was a real welcoming mood here. And a number of colleagues had mentioned about yoga and strength from reflection with colleagues. Sadly, I'm not an expert in yoga, but if I was, I could certainly see evidence of that here today. And I think when you have that attitude and that openness, it encourages other people to perform and to be the best that they can be. And I think that for me was really very, very evident. I think everybody was made feel very welcome. Obviously, I can't speak for Jenny, but I'm sure she equally was made very, very welcome and participated excellently, of course, in this last couple of days. In terms of Gujarat, I love India, everybody knows that. I'm Irish and we share loads of similarities with Indian people. Even our flag has the same colours as the Indian flag, so I'm very biased in favour of India. So I'll move on from that one. But I think my overall impression is that this is an excellent conference, and I think that the organisers have done a wonderful, wonderful job. And I think that it's not just 10 years that they celebrate, but I would not be surprised if it goes for another 110 years. It was a fantastic trip.
Thank you, sir. Your kind words. Thank you. So now today's our chief guest, Dr. Mehul Shah. He is basically the president of Gujarat State Branch IMA, and he is current council member of GMC. So Dr. Mehul Shah, sir, please give us few words. Thank you, sir.
Hello. Good morning, everybody. Thanks for inviting me as a chief guest in this auspicious conference of Gujarat State Branch. We have a number of legacy on the stage and so many colleagues, friends, and seniors and juniors sitting in the auditorium. It's a wonderful day for the IMA as well as Gujarat Medical Council to address such august gathering and to give some message and some observations to the very respectable, life-saving team of the Gujarat. You are the main person to give a comfortable, commendable position to the family. You are the main person, your team is the main person, your team is the most important vital role in the health structure. And your role in a health structure is very crucial. And by virtue of your responsibility, your expertise, your commitment to the society and the patients and their relatives is most important. Your academics are very bright and your curriculum is very strong to take care of the patients and their illness in form of morbidity and the terminal event. But since last so many years, we are observing some disturbance in the community and the society. And how to address such type of things? Recently, in last 1 month, we are facing in Gujarat state with so much of turmoil in health industry and health structure. So what are the lessons from this type of incidents? There are so many things to learn. Government of India has just put the one draft resolution, withdrawal of life support. I have published in my medical assistant bulletin. They have asked for some suggestions. It's very beautiful draft. It's in draft fashion. And we are the person as a health structure and health person, and you are the main person. How to define this draft? What are the additions, subtractions? What is our need to safeguard the society and as well as the medical profession? Ultimately, when some mishap happen in a hospital, in ICU and in critical care, ultimately target is our doctor's team. So it requires tremendous introspection in our team, how to improve our relationship with the patients and their relative. The sir has suggested so many academics in NMC, so many courses upgradation and so many guidelines for this in future for the academics. But simultaneously, in our courses, there should be some part of two things is very crucial. One is human behavior. How to talk with the patients, their relatives, communication skills, counseling skill, that is the most important part. When I am working in one hospital as a medical expert or medical support, always I ask my hospital's team how to talk with patient's relative when the patient is in ICU. What is your role? How you are communicate each and every event in a patient's relative. Communication, counseling, and consent. These are the three main pillars of our critical care. Is part of treatment, it's part of management. To reduce the stress in form of health structure and as well as in the society and in the family also. I always request our team to do internal audit every month or in every quarter. What we lacking is the most important part. In any outside health structure in USA, UK, Europe, anywhere you go, always there is an internal audit team in each and every department, each and every hospital. It is our dictum to start such type of journey. What we can do more better for our mortality rate, what we can do more better for the morbidity rate, what is the rate of the intubation, what is the rate of the ventilator. There are so many points to audit by our team as well as the external audit also. There should not be any partiality. It's only exclusively of the scientific matter. So we have to learn, we have to identify the risk factor, and we have to identify the problems and obstacles during the line of treatment and how to improve, like antibiotics. AMR is a very crucial problem in India. And WHO, and they have started also a program for the AMR. Next Sunday we have in train the trainer workshop from all over the India, and WHO people are coming to the Ahmedabad to start this trainer program for AMR. So it requires tremendous knowledge for the behavioral things, and simultaneously I am also giving some tips about the medical policy, law and ethics since last 10 to 15 years. It's a changing scenario. Every 5 years, 10 years, there is a change in the medical policy, law and ethics. My request, humble request, in each team, suppose you are working in a team, in any hospital, you have 5 members of team, 7 members of team, 10 members of team, you have very good networking. Out of one member in your team, he should have a vision for the legal aspect, how to safeguard the documents, how to safeguard our medical properties. And fortunately, because they started GNLU, this program, the diploma course, for upgradation of our knowledge in form of legal aspect. So my humble request from the Gujarat team and beyond the Gujarat team, it's an online course. Everybody from your team, they should have some vision, the knowledge about the recent operation of the medical, what are the medical policy, what are the legal aspect, what are the law, what are the ethical issue, and everybody should have one person from your team, he should have such type of knowledge and upgradation of the legal aspect, so that it can save your so much of energy. How to documentation, what is the consent, what is the certificate, there are so many things in this course. My humble request is to enroll from your team to give a legal safeguard. It's a preventive measure to reduce the number of cases in the medical council and in a consumer forum. We are receiving so many cases since last 3 to 4 years. It's a very high speed, the incidence which are increasing in council as well as in the consumer forum. So my humble request is to do introspection, internal audit, and enroll from your teammates to have such type of legal knowledge about the recent in our India. These are some suggestions. Now I'm asking you some things from your team in a two-part pathway. One, there are so many problems and so many gaps you are seeing in your day-to-day practice. I think Gujarat has tied with the ICON. It's a very beautiful institute of the government of Gujarat. They want some medical innovations. They want some medical startups in ICON. The friend of me, Mr. Mahanta, is a good friend of our Dr. Tushar Patel. He has introduced with IMA Gujarat. He is the main person, the Dr. Tushar Patel. I request all of you, young doctors, just visit the IHub. Give your thought, give your query, give your gap, and they will support in any form of medical innovation startup. Unfortunately, our B streams, science streams, medical professors are not coming to such type of new startups and innovation. You are a brilliant person. You are a brilliant doctors. You have a definite some vision, some obstacles, some problems, some gaps in your day-to-day life in a critical care in ICU or in an emergency room. You identify that gaps. Discuss with the technocrats. They will support anything from the technology to the funding also. So I request all of you to have a visit to iHub with the help of Tushar Bhai. It's a very beautiful setup. Just start igniting your brain about the innovation and startup. You are the main person working in a medical equipment area and biomedical engineering. You are the main person behind the whole show. My request, Tushar Bhai and team, visit your whole team in a coming year in iHub. And second, my personal suggestion, you are the main person to give a last signature of the dying declaration. You are the person who declared the death in ICU. But my humble request is, how many of you have an ability to take the eye donation? How many of you have taken eyeball from that body? Anyone in this auditorium? No. Only one. Why? The recent guideline from the government of India, any person trained not a medical professional, not a medical degree. Any compounder, any person with training, he can take the eyeball. You are the person, you are declaring the death. There is a huge gap in a corneal transplant requirement, huge gap in eye donation. You are the main person, you have to train your staff, and you have to ignite your mind and open your vision and sight. I am orthopedic surgeon, but I'm not able, I'm able to do the amputation. I'm able to do the fixation of the fracture, but I'm not able to take the eyeball. Just because of lack of knowledge and lack of training during my medical profession, medical career. It requires only 5-7 days or 15 days. You are the person, you are declaring the death, you have a signage, the last paper on the patients. So simultaneously you have to encourage such type of movement from your home ground or ICU, whatever from a hospital. And how to take up this thing, it's your part, it's your role. So my humble request is to start this type of thinking in your team and in your hospital. And the second thing, again, very social thing, need of the time, organ donation. In Gujarat, highest number of organ donation in civil hospital. 130, 150, 170, it's around 175. Why only in one hospital? Why not in any other hospital, in any ICU or any hospital in the government sector or in the private hospital? Why it is so? It's lack of knowledge? No. We are the expert. We are going to declare the brain death patient. But the next step, after deciding the something, the condition of the patients, you also know that this patient is going to die within short time. You are the main person who declared the death. There is a crucial time between this moment. And how to utilize that moment, how to motivate your institute, how to motivate your team, how to enroll the transplant coordinator in your team, the social worker, whatever things. It is our humble responsibility to do such type of activity in our city, in our hospital, in our institute. So there is again a huge gap in liver transplant, lung transplant. There is a surgeon sitting in the from the UK said, Tushar said he's a lung and heart transplant. But in India, unfortunately, the stimulus given to the critical care team to support such type of things, that is my humble request and message. There are so many things to deliver, but there is lack of time. We can meet again for the such type of things, but my request is to enrich your knowledge in form of legal aspect, understand your responsibility of your practice so that the society does not have any black effect, any black dot in our profession. Always do some ethical practice. So many places from anywhere, from the world or environment, we need to stick to our Hippocratic oath. We stick to the ethical practice. Don't surrender anything to any person or any system. In future, and save our society. That is our main motto. Thanks for inviting me. Thanks to organizers.
Thank you, sir, for such a nice words and highlights. So now we felicitate whole organizing committee to Dr. Mehul Shah, sir, with Momento. So we whole organizing committee, Dr. Amit Prajapati, Dr. Brijesh Patel, please come on the stage. He is conference coordinators. So all we felicitate Dr. Mehul Shah, sir, and we felicitate by Momento to Dr. Mehul Shah. Yeah. So now, word of thanks by our treasurer to few words. Only thanks by Dr. Amrish Patel. Word of thanks.
Uh, Good afternoon, everyone. First of all, I would like to thank all the person, those who are involved in making this 10th Gujarat Criticon at a very grand successful level. So, every doctors, every committee members, every faculty, those who are coming, Professor Brandon or Professor Jenny, along with our national faculty, Pradeep Bhattacharya, Dr. Srinivasan, Kapil Burawake sir, all state faculty, very thankful to you. And on behalf of organizing committee, I would again say thank you very much. And not last but the least, Pharma Committee for being academic and aggressively support for making this event at a very grand successful. And in future, we are always try to involve you in these academic events so we can share our knowledge to committee. Thank you very much.
All the guys, please make one photograph and we have make one anthem for our critical care. So please, so all have to stand up and we are going for national anthem of critical care medicine, specially launched this year. So all and Dr. Abhi Prajapati and Dr. Brijesh Patel come on the stage for photograph also.
We will dance so we can, night and day. We are in place that is fearless in every way. We stand tall, colors of light. We fly to all. Beating and training, bringing forth the light. Pumping the stock, heart are heroes for you. Witness lights and healing we always thrive. Facing challenges to make us actually thrive. We are ISCC in our hearts of clay. In the darkest stars we light the way. We are the warriors that we defeat. With our sharp knowledge and skills so we are होगी हमारी हमें sleeping monitor and ventilator chaos. Just preparing for blues to stroke feet they are. With our beauty and get your mission. We are unstoppable in our question mission. I guess and you are the pride. May you shine a beacon through time. We are the warriors that we defeat. With our sharp knowledge and skills, so we are mighty. होगी हमारी होगी हमारी
So hogi hamari ji. So we proud as an intensivist. Huge round of applause for ourselves also, please. So that's the end of our inauguration ceremony. Thank you, Dr. Mehul Shah sir and all the special dignitaries on the stage. A few announcements about the quiz. So congratulations, winner. I just announced and on the screen that students from Satbir Agrawal, Dr. Dharan Modi, Dr. Hardik Dave, Dr. Jigalli Tejani, Dr. Parman Jai and Darshi Chauhan. Those are the winners in the preliminary rounds and they are qualified for the final round of quiz 2024 IPL. So all are congratulated, heartily congratulated. And consultants Dr. Mehul Gajar, Dr. Guj, Dr. Aneri Patel, Knowledge Kumar, Pranav Patel, and Divyang Vyas. These are the consultants who are the winners of preliminary round, and they are all qualified for finalists. Next list would be if they will not present in the final, so this list will be next slide. Those are the students. Next slides. Waiting list, last. Waiting list would be that, and all would message would be that waiting list. Yes. So these are the weighted list would be if જો આ બધા ફાઇનલમાં નહીં હોય તો એમની જગ્યાએ આ લોકો ક્વિઝ રમી શકે છે ફાઇનલ. Those are the list. Soeb Beg, Jeet Thakkar, Sweta Kaushal, Hinal, Surbi Wadi, and Vishal Prajapati. And from consultants, Vipul Patel, Ankit Mankad, Dheeraj Patel, Sanjay Sheikh. So આ લોકોને પણ ફાઇનલમાં પ્રેઝન્ટ રહેવા માટે વિનંતી છે because they will also get a chance to play a final of IPL. So all are heartily congratulated and they are the qualified for the final. Thank you.
I would like to call upon stage our next chairperson, Dr. Yogesh Vagela, Consultant Critical Care, Phoenix Hospital, Ahmedabad, Dr. Kamlesh Patania, Senior Physician, Ahmedabad, Dr. Parth Shah, Consultant and Intensivist at Jivraj Hospital, Ahmedabad. Our next session is going to be conducted by Dr. Kapil Borawaki on intestinal ischemia in critical ill patients. The lecture has started in Hall B, Hall Sabarmati. Dr. Parth Shah.
Hello. Good afternoon, everyone. I would like to invite the next talk. Dr. Kapil sir from Pune. He had done the DNB Medicine, IDG, CCM, FICCM. He is affiliated with Director Critical Care and Senior Consultant Department of Medicine, Sahyadri Super Specialty Hospital, Pune. Sir, area hospital is critical medicine. Please, sir.
Thank you very much, and thank you entire Gujarat team for inviting me for this event. It's always a pleasure to come here and talk about interesting aspects of critical care. And here one more interesting aspects of critical care, that is intestinal ischemia in critically ill patient. When we come across these kind of scenarios, it's very important for us to understand that when I'm talking about the intestinal ischemia, that is I'm talking about mesenteric ischemia. And mind you, it is a life-threatening disease or life-threatening condition, and probably the entire reason for that because that gut which is requiring the sufficient blood supply is not been there. And if we don't treat, it's a malignant condition. If we don't treat, definitely it is associated with increase in the mortality in the various ways. Whatever changes in the advancement of the treatment have happened and investigation modalities have come across, I feel this one condition is always a nightmare for a clinician bedside. If we have gone through the literature over the years, the awareness has increased, that has helped to reduce mortality. For now, today the mortality is around tune of 10 to 20%. But also, good mortality is if you are able to identify the condition early and treat them within the first 6 hours. So, key here is early diagnosis of this condition is very important. So, if you look at the mesenteric circulation, 3 important things or 3 parts which you should be able to understand. That's why we understand which part of the gut is under threat. One is celiac axis, superior mesenteric artery, and inferior mesenteric artery. So whenever we think about the most important problems happening due to mesenteric ischemia, it is mostly due to superior mesenteric artery. The area supplied is the duodenum, jejunum, ileum, ascending colon, and proximal transverse colon. So probably a large area of colon is supplied by this artery. So most commonly this artery is involved. Now, Why this is important? Because probably we are differentiating these into two types of disease. One is occlusive disease, which is actually causing reduction in the blood supply, and second is non-occlusive disease. So if I talk about occlusive disease, these are either mesenteric arterial embolism in around 50% of the cases, mesenteric arterial thrombosis around 50 to 25% of the cases, and mesenteric venous thrombosis in around 5 to 15% of the cases. So if you classify these into arterial occlusive and non-occlusive disease and what are the risk factors, the important risk factors for occlusive disease, particularly arterial occlusive disease, are atrial fibrillation, myocardial infarction, heart failure, and prior embolism. If it is a thrombotic event, maybe coronary artery disease, peripheral artery disease, tobacco use, so something which is narrowing the arteries. Symptoms we will discuss. Then if you talk about non-occlusive disease, most importantly, end-stage renal disease, again, heart failure and high vasopressors. And if you only talk about venous disease, that is prior history of DVT, PE, recent surgery and hypercoagulable state. Now, why these factors are important? Because when you are examining these patients, when you are thinking about what could be the possible cause for this acute abdomen, then if these risk factors are there, your index of suspicion will be very, very high to think about mesenteric ischemia in this group of patients. We will look at the embolic acute ischemic states. As I already said, it is mostly due to SMA occlusion, particularly in the patients who had arrhythmia, cardiomyopathy, or valvular disorders. They are at very high risk of development of mural thrombus, which eventually embolizes into the mesenteric arteries. Now, out of this 50% will block SMA, 50% will block middle celiac artery, which is the first major branch. So again, more than half of it is within these two branches. If you look at the thrombotic episodes, the slight difference between these and embolic is they are slightly progressive in nature and slow and steady in onset. So that they differentiate them from the embolic episodes because they are developing over time. The problem here is the symptoms are usually very vague, so unless you think about it, probably you may miss it. Looking at mesenteric venous thrombosis, again, thrombosis of superior mesenteric venous system, and the important risk factors are, which I already mentioned, are the risk factors for hypercoagulable state, that is disorders of factor V Leiden, protein C, protein S deficiency, or antithrombin 3 deficiency, or any hematological disorder, and importantly, patients who are on oral contraceptive pills. Vasoconstrictors which get released as a part of moths, they will probably leading into DIC and leading into reperfusion injury. The risk factors for these non-occlusive diseases are again sepsis, acute myocardial infarction, elderly patient, end-stage renal disease or liver disease, major abdominal surgery, and autoimmune disorders also like vasculitis. If you classify the symptoms or plot the symptoms, the important symptoms are abdominal pain, nausea, vomiting, diarrhea, rectal bleeding. Most important is pain which is out of proportion of the disease and diffuse tenderness, peritoneal signs, distension and tachycardia. If you see these symptoms, this can be there in any critically ill patient also. So what is important is to understand the clinical triad when I'm talking about an embolic disease. If a patient who is in ICU develops acute severe abdominal pain, diarrhea or vomiting, and with presence of some kind of risk factor like atrial fibrillation, then probably you have to think about embolic ischemic. Now, pain here again, I'm repeating, the pain is generally out of proportion of the clinical signs, and you may not be able to locate the pain to a particular point. So this non-localization will again will point out towards the mesenteric ischemia. Now there will be various phases through which that initially patient will have a pain, then in phase 2 they settle, but in phase 3 the pain again reappears. So when you are in dilemma, when you have repeated pain which is not going, you have to think about mesenteric ischemia. Already I have talked about thrombotic occlusive disease. They are more challenging because course is very vague, but few clues. The patient may have a presence of some atherosclerotic disease or with history of weight loss. Somebody who has got peripheral vascular disease develops slow weight, reduction in the weight, or probably more than 10% of weight loss. We have to think about this thrombotic occlusive disease. Mesenteric venous thrombosis is an uncommon condition, and usually, as I already mentioned, it is associated with hypertension. Then there is a group of patients, particularly younger group, where somebody suddenly develops abdominal distension, dull aching abdominal pain, nausea, vomiting, bloating over a year, over the days, and with history of hypercoagulable states, you have to think about it. Same with non-occlusive states. The important difference here is presence of rectal bleeding. Any patients who has developed severe abdominal distension develops rectal bleeding and who is intolerant to oral or enteral fluid, you have to think about non-occlusive disease. Now this patient might be sedated, paralyzed, multiple vasopressors, or calcium channel blockers, digoxin, which will put him more at risk because of the vasoconstriction. Again, this patient may not be able to talk to you because they are sedated, paralyzed, ventilated. So clinical features will be very vague. So what we should have a high index of suspicion. These all patients, usually they are fluid deficient due to their decreased fluid intake and probably abdominal third spacing happens to have fluid. The few lab parameters which are not very specific, but you will have a leukocytosis, you will have a hemoconcentration, your lactates will be high due to ischemia, your blood gas may show high and metabolic acidosis. D-dimer will be raised, but it is very non-specific. Patient may have abnormal renal or liver parameters, and your LDH will be elevated. Patient will have high phosphates and high potassium, probably usually late in the disease, and they represent bowel infarction. So somebody who is sitting in ICU more than 3 to 4 days, phosphates has gone up, potassium has gone up, renal functions are normal, not on any drug which is causing hyperkalemia, you have to think about mesenteric ischemia. The first investigation what we think about after lab is X-ray. X-ray is very non-specific unless somebody has developed bowel perforation or free gas in the diaphragm is seen. It is very difficult. So most of these patients will have normal abdominal X-ray. So what helps is CT scan. Now as per American College of Radiology and most of the societies, the CT angiography is the gold standard for the diagnosis, particularly with very good sensitivity and specificity for these mesenteric ischemias. It not only helps in evaluating vascular cause, but it will rule out the other bowel abnormalities also. So you should have another differential diagnosis. The arterial, 2 minutes. Arterial phase will highlight vascular morphology, and venous phase will talk about bowel wall thickening. There are a few specific findings. Again, this is showing SMA thrombosis. In non-occlusive disease, the classical findings are usually, they are non-specific, but they may support diagnosis. There is narrowing of SMA, irregular counters of branches of SMA, and spasm of vessels, and impaired feeling of intramural vessels. Plus history will help you in this. Sometimes you have to do non-contrast CT or contrast CT in AKI also if you feel the cause of AKI is pre-renal. Coming to management, fluid resuscitation, good intensive care backup, electrolytes, vasopressors. Antibiotic use again questionable, but probably giving antibiotics sometimes helps. Though we have to be aware about antibiotic resistance, what we thought about in the morning. Then keeping them nail by mouth usually will help because if you have to prepare them for surgery, anticoagulation is very, very important. And as I said, they may have hepatic or renal dysfunction, so we have to be aware of this. If renal dysfunction, I'll prefer unfractionated heparin. There are a few definitive therapies like endovascular repair, surgical repair, and there is something called damage control surgery. Probably when we are very not sure, probably take the patient to OT after CT and try to see where is the issue. If you feel a gut which is non-viable, to remove that, because if you are not able to remove the source of that sepsis, probably then you will land in trouble. So that's something called damage control surgery. Definitive surgery, you can do it later. For non-occlusive disease, you have to treat the cause. Post-operative management in intensive care is very, very important, and then we always discuss between surgeon and intensive care people about giving fluids, giving antibiotics. But we have to be very sure that we have to prepare this patient for second surgery also. Plus, we have to avoid him from going into multi-organ dysfunction and ventilator-associated pneumonia leading to ARDS. So, to sum up, if you have a suspected ischemia in gut, and if there are signs of peritonitis are present, then you can probably go with CT angiogram. If patient is stable, fine, you can wait. But if your patient is unstable and gut is the cause, then you have to do the damage control surgery. If peritonitis signs are absent, still you have to go ahead with CT to differentiate between embolism, thrombosis, and accordingly you have to treat. And more challenging cases are non-occlusive ischemias, where you have to probably treat with some to avoid vasopressors. It's very easy to take. There is a lot of debate about vasopressors causing mesenteric ischemia, but sometimes we have to have that high blood pressure also to have good perfusion. And vasodilators are being used, but in my practice till now, I have never used vasodilators for these patients. But use of heparin is probably helpful for this group of patients. So thank you very much, and it's my pleasure to invite you all for Critic Air 25 at Kochi. And your abstract date is 10th December. Thank you.
Thank you, sir, for the excellent talk. Any questions from the audience? I think sir had enumerated very nicely the intestinal ischemia. Thank you, sir.
Thank you so much, Dr. Kapil Borawati, for an interesting discussion. Now I would like to call upon stage for our next session Dr. Srinivas Samvedan, an insight to prevent multi-organ failure.
A very warm welcome to Dr. Samvedan sir. He is consultant Ramdev Ram Hospital, Hyderabad. Over to you, sir.
Good afternoon, and it's a privilege to be here at GUJCRITICON. This is my 9th consecutive GUJCRITICON, a lot of friends here, and also I'm happy that I'm here on the day when my friend Raj Raval celebrates his birthday. Many happy returns to Raj. We begin our discussion on the prevention of multi-organ failure. So this is not about sepsis. While we talk about multi-organ failure, most of us think this is sepsis, but any condition, any disease which produces a systemic inflammatory response can have the potential of triggering a multi-organ failure. The mechanisms might be different to begin with. End of the day, the final common pathway comes through the gut permeability, the capillary leak, and the dysregulated immune response and organ damage. When you talk about multi-organ failure, you talk about neurological dysfunction, respiratory failure, hematological failure, hepatic dysfunction, renal dysfunction, and gastrointestinal failure. All these are the constellation of manifestations which can produce multi-organ failure. One of the essential insights we should have into the pathogenesis and origin of multi-organ failure is that when a single organ fails, there is almost always an organ crosstalk. If a patient with pneumonia may be in altered sensorium not only because of the hypoxemia which the respiratory failure is producing, but also because of the inflammatory effect on the CNS. Similarly, somebody who has a pneumonia and is being mechanically ventilated can have an acute kidney injury independent of his volume and pressure status, and this is related to the lung-kidney crosstalk that happens. So every single organ that is dysfunctional in the body attempts to have a crosstalk mechanism with other organs, and this actually is the pathophysiology and the crux of why multi-organ failure happens in quite a lot of patients. So what are the influencers? This is the era of influencers. Actually, somebody who's called some chaiwala actually has more followers than some of our army veterans, right? So this is the era of influencers. So what are the influencers which influence the pathogenesis of organ failure? The most important concept is the concept of perfusion pressure. So it is not only the brain which thrives on cerebral perfusion pressure, there is mesenteric perfusion pressure, there is renal perfusion pressure, and there is a perfusion, a coronary perfusion pressure. This is one concept. What fluids you give, when you give, how much you give, and at what point you stop giving them is another important determinant of the pathogenesis of multi-organ failure. When do you start vasopressors? Do you start them early or do you start them late? Also influences whether your patient develops multi-organ failure or not. Some of these mechanisms are mediated by free radicals, and how effectively you can break this free radical mediated damage is an important determinant of how you can avoid multi-organ failure in your patients. It is logical to think that if the body is deprived of oxygen, give oxygen to the patient, but how much oxygen is too much oxygen? Hyperoxia also is as harmful as hypoxemia because the body can adapt to hypoxemia, but there is no adaptive mechanism that is inbuilt into the body to overcome hyperoxia, and that is a concept we should understand. Extracorporeal supports, we initiate CRRT, we initiate ECMO, we put the patients on plasma exchange. Heart failure patients go on ventricular assist devices. These devices, how they talk to each other, a device-to-device crosstalk is also an important determinant of the origin of multi-organ failure, and a little bit about understanding about metabolic resuscitation. This is the hemodynamic pyramid, which is based on the supply balance. So this is the basic pathophysiology. So you have the blood pressure which drives and the vascular resistance which drive the organ perfusion and tissue metabolism. So the perfusion pressure and your metabolic failure are the apex of the pyramid leading to the supply demand balance. And you have a lot of parameters by which you can measure the way your perfusion pressures are going. End of the day, you need to maintain your perfusion, and the blood that is being perfused has to be oxygenated well. This is the crux of critical care. Making blood go round and go air in and out is the crux of critical care. So if you can ensure that your perfusion pressures are optimal and the blood that is circulating is optimally oxygenated, then you would be achieving a lot of progress in preventing multi-organ failure. So these two, therefore, are the crucial principles on which we look at perfusion pressures in the patient. So if you look at organ perfusion pressure, the extremes of organ perfusion, the highly vasoconstricted state of cardiogenic shock or hypovolemic shock as an example, and the extremely vasodilated state of septic shock as a prototype are conditions associated with hypoperfusion. The intermediate range where then you have to play around with your intravascular volume and your vascular tone is what is determined by your vasoconstrictive reserve, which minimizes the risk of hypoperfusion. So if you have to avoid patients going into multi-organ failure, you have to play with their hemodynamics and their volume status in this vasoconstrictive reserve. Because the curve is a sigmoid curve. So the plateau is, it starts kicking in very fast and then it becomes a plateau over a period of between 50 to 100 millimeters of mercury. So end of the day, when you look at patients who are hypoperfused, whether it's a coronary perfusion pressure, whether it's a mesenteric perfusion pressure, a pressure of between 55 and 70 seems to be the determinant of avoiding hypoperfusion in a low blood pressure state. So how can you assess this? You have multiple tools at your disposal currently to understand the perfusion pressures in different vascular territories. You have the transcranial Doppler for the brain. You have the echocardiogram for the heart. You have the abdominal ultrasound to look at the mesenteric vascular permeability and the index. You have the renal resistivity index which you can measure, and you have the splenic Doppler resistivity index. This is the sonographic assessment of perfusion pressures. Clinically and laboratory wise, you can assess them by looking at the mentation. You can look at brain tissue oximetry. You could look at the SpO2. You could look at the AVCO2 delta and a lot of other things. But the simplest, most effective, and the most replicable tool which is available in our hands is the capillary refill time, which has been found to be equivalent to lactate clearance in understanding whether your perfusion strategy is working for the patients or not. Next is the fluid stewardship. We spoke about antimicrobial stewardship. We need to get that discipline into fluid therapy as well, because the type of fluid you use, the volume of fluid you use determines your global interstitial perfusion. It compromises perfusion. A hypervolemic patient, somebody who is volume overloaded, is as likely to develop acute kidney injury as a hypovolemic patient with all the attendant complications. So if you look at the 7 hours of fluid resuscitation, you have to resuscitate the patient, look at the maintenance, replace when there is loss, when there are losses, and you re-energize the nutrition. You should avoid getting into the phase of de-resuscitation of the patient. The moment a patient goes into the phase of de-resuscitation, something somewhere has gone wrong in your initial resuscitation strategy. So just to put it succinctly, no starches, no gelatins, no high volume 0.9% saline, and no 5% dextrose as part of the resuscitation strategy. What should work is balanced salt solutions, blood, and in extreme situations of septic shock with an albumin of less than 2.5 in the first 6 hours, maybe 20% albumin, except in the scenario of traumatic brain injury. So this is the situation where you find that if there is a patient with extraperitoneal infection, even in a cirrhotic patient or in a traumatic brain injury, albumin is harmful. It is definitely recommended in sepsis resuscitation after large volumes of crystalloids in SPP, HRS, and large volume paracentesis. But we don't know what happens in the septic patient. We don't know what happens in the cardiac septic patient. We don't know what happens in patients with so-called diuretic resistance. So if you remember this, you can bring in the discipline of fluid stewardship into your practice, and the timing matters. When do you give fluid? So the minutes mnemonic is the one where you should be using for when to give fluids and when not to give. May infuse the fluid, but investigate, is my patient still volume responsive? Every volume responsive patient may not take volume. Right? They may not, if you get a test on a dynamic index that is volume responsive, he may not respond. That is because of the intra-abdominal pressure and other correlative. So you need to look at ultrasound, look at the vexus, see whether the kidneys are overfilled, or look at the portal vein, the hepatic vein, and see whether there is hypervolemia. Treat the etiology and stabilize the patient, and you should be able to assess this in a very short time of 20 to 30 minutes. Next is the oxygen target puzzle. How much oxygen is too much oxygen? It is very clear that patients with ARDS, if you use a conservative oxygen strategy, the outcomes are bad. But all other patients, except in traumatic brain injury and in the pregnant lady who comes into ICU with a critical illness, conservative oxygen targets with a PaO2 of between 60 to 70 and a saturation of about 85, around 85 to 90 is good enough. And if you try to achieve a higher target, you end up doing more harm to the patient. Lastly, we look at the crosstalk concept. As I said, you put a lot of patients on mechanical ventilation, ECMO, and on extracorporeal liver supports. Long ago, when Amato did the low tidal volume study, he demonstrated very high levels of interleukin-6 in the bronchoalveolar lavage in patients who were ventilated with high tidal volumes and high respiratory rates. That means your strategy of mechanical ventilation actually triggers a systemic inflammatory response. So you should be conservative in your ventilator targets as well. Similarly, if you initiate RRT, it has implications on ECMO, it has implications on ECOR, and it has implications on plasma exchange. So what is this device-to-device crosstalk you need to understand? Finally, the 3 important molecules which are making waves and names and buzz in intensive care circuit: vitamin C, methylene blue, and ascorbic acid. Vitamin C is an antioxidant which has a role in steroid and catecholamine synthesis and on immune cell function. it's supposed to improve function, and it is documented that in critical illness, the circulating levels of vitamin C are 20% of what they are in health. So a 6 to 8 gram dose of vitamin C is supposed to increase these levels. Unfortunately, randomized controlled trials have not shown clinical benefit with the isolated use of high dose vitamin C. So also with methylene blue. Methylene blue is a free oxygen radical scavenger, and it is supposed to improve the vasomotor responsibility to catecholamines. And as has been shown in multiple studies, if you initiate methylene blue in patients who are in advanced vasodilator shock, the responsiveness to norepinephrine improves, and later on the dose of norepinephrine actually comes down. Again, large randomized controlled trials are currently on, but as of now, I can't make a grade 1A recommendation and say methylene blue could be used in all patients with septic shock. Hydroxycobalamin, another important molecule which has a lot of role to play in the ATP pathway, has been shown to reduce the vasopressor requirement, has been shown to improve the mean arterial pressure when given in a dose of 6 to 8 grams per day. Again, we need to understand that these are not yet proven by large trials. Some trials are going on, and maybe next time when we meet, we should have some understanding. Lastly, the last slide. So if you have an early shock, identify and treat the underlying cause, judicious fluid resuscitation, early vasopressors. In severe shock, correct other aspects like acidosis, electrolyte imbalances, and adrenaline insufficiency. And in late stages, consider ascorbic acid, maybe methylene blue, and hydroxycobalamin in the future. To summarize, multi-organ failure still remains an enigma despite all the advances in science, because multiple players are involved. Understanding of this whole concept of multi-organ failure in a lot of conditions apart from sepsis like burns and trauma is improving. Judicious fluid therapy is beneficial, but the most important thing you need to remember is defending the perfusion pressures is crucial while avoiding secondary insults. And as we have seen towards the end of this presentation, older therapies like methylene blue and vitamin C are re-emerging in our armamentarium of tools we have for preventing multi-organ failure. Thank you very much. If you need any articles related to the talk I delivered, please write to me on my email ID and I'll be happy to send them across to you. Thank you. Have a good day.
Sir, as you have mentioned that vitamin C, hydroxycobalamin and methylene blue do not have any grade 1A recommendation. If I want to ask you what's your personal suggestion, personally if you have used, how do you found that will help in patients with septic shock?
We published a randomized controlled trial three years ago on the IJCCM, where we have studied vitamin C, ascorbic acid, and hydrocortisone as separate entities in patients with septic shock, published in IJCCM, reviewed by Dr. Farad Tapadi. What we found is that hydrocortisone, as we all know, has some role. Thiamine doesn't seem to be working, but high-dose ascorbic acid, when initiated at the time of initiation of vasopressin, actually reduces the norepinephrine dose and allows you to get the vasopressin off faster. We could not show a survival benefit because of the smaller sample size, but we have definitely shown a decrease in the vasopressor. As far as methylene blue is concerned, we have been using it for quite some time in advanced vasodilator shock, but the flip side of the story is most of these patients who are in advanced vasodilator shock are also oliguric. So you can't give methylene blue in a patient who is oliguric. So invariably we end up initiating CRRT on these patients. So if you put methylene blue in somebody who is on advanced vasodilator shock, we are obliged to put them on CRRT. That's the flip side. But as the studies have shown, it does reduce the dose of norepinephrine, but survival benefit I can't vouch and say it is.
Thank you. Thank you for excellent talk.
Thank you, Dr. Srinivas Samvedam. We really appreciate the clarity and depth of your lecture. Now I would like to call upon stage Dr. Kapil Boravake for his session on family-centered care in ICU.
Yeah, good afternoon. Here probably a very different aspect of intensive care medicine I'm going to talk about is family-centered care in ICU, and probably this entitles patient and family first approach in critical care. And I think we are in an era we are slowly shifting towards this kind of uh, critical care also. What is mean by family-centered care? It's basically an approach which recognize families also as an important part in patient care. So what has happened now, the way we take care of patients now, that everything is done by us and family is left aside. So some sort of care where family is a part of it, and probably I think this kind of change in the therapy is definitely going to help us in some other ways also. Now, why this is important in intensive care medicine? Because we have to understand that when somebody is critically ill in the ICU, it's not only patients who is suffering, and the entire family is also suffering. And whatever best we are doing, where probably sometimes we feel we are doing the best for the patient, and then we have to understand that what family is also going through. Now, those few patients where the patients can talk, these families can provide emotional support to our patient also, and definitely they will help us in decision making. There are few key principles in family-based critical care medicine. That is, you have to have dignity and respect to the disease, and dignity and respect to the patient also. And this is very important aspect. So what we are trying to do by this kind of approach is we are giving them that importance, that dignity and that respect. Second important aspect is information sharing. Amount of information that needs to be given to the patient's relative has to be very clear. And there were days where when relatives and patients used to ask what is happened to me or how I'm going to be treated, the what answers were given were not that logical, or probably consultant used to feel offended if somebody asked this question. But now we are in an era where this information sharing has to be very precise, in very simple language, very clear, and it has to be given repeatedly also. Many times it happens that when probably morning somebody asks some different relative, afternoon some different relative, evening some different relative. Now if we have this family-centric approach, so probably we are making one person from a family probably a dedicated person or dedicated there to take care of that patient. So there also it will help us to disseminate information about patient care also. And that will definitely lead to more participation of family in caregiving, than let them understand what we are actually doing. So it is a collaborative approach between patient, family, and we ourselves. Now, what are the benefits? If you look at, there are three aspects. One is what is benefit to patient, benefit to families, and benefit to us. Definitely, patients will have reduced anxiety, reduced delirium. There are many papers which have shown that it had improved outcomes, but it has gone the both ways. So for now, we can say probably it will some way help to improve outcomes. Definitely, it has shown to improve recovery, and adherence to care plans was much better when such care was given, and definitely better emotional well-being in the patients. If you look at the for families, again it's the same: reduce anxiety, reduce stress, and probably improved understanding of the patient condition. We may not have the relatives which are of same educational background, same IQ, but more and more they spend time with us, they try to understand us. I think they become better, and that gives us more satisfaction about what kind of care we are giving to our patients. And for us, what will be the benefits? There will be fewer conflicts and fewer misunderstandings, and probably improved team efficiency and communication. So what are the strategies to implement this? One is we should have flexible visit time or visit policies to our patients, relatives. We should have a regular family meetings, emotional and psychological support groups, shared decision making, educational support and cultural acceptance. So what is meant by visiting flexible facilities? That is allow family to stay with the patients. Let them be there. Let them understand what is the environment there. Maybe probably you should have some kind of activities going on where there are waiting areas, or you can have audio visuals. There are something called as ICU family rooms, you can call them. You should have more family meetings where you should have very clear language, less of bookish language, non-technical language, and you should provide a very regular update for the patient. Emotional support via counseling, peer support groups are very, very important. And educational support, like what we are doing for organ donation also, some kind of information about the disease and what the patient is having by somebody who is not a healthcare provider is more acceptable to this group of patients. So probably you have to engage more and more non-medicals in the team for this. Then you have to understand what are the patient's cultural needs, religious values. You have to interpret them, and probably that has to be taken into consideration when you are taking any decisions. So in nutshell, probably you should have good family invitation, good orientation, active engagement, communication follow-up, questioning. So important is you should create a picture about progress, plan, prognosis, and potential problems. If you can create this, so the kind of trust which has been created into their mind about what kind of care we are giving becomes more easy. But what are the challenges? The time constraints for us to spend this amount of time with the relatives is very, very difficult. Sometimes if patient, the family is around, suppose I'm taking around for now 5 minutes, maybe when the relatives are around, that might double my point. Then patient privacy, and if more and more relatives are there are procedures, many things, monitors, buzzers going on, many false alarms. So how they are going to take it is still a big question mark. That can put a tremendous stress on healthcare provider also. Plus, these kind of values may put emotional strain on the families, plus the staff also. And sometimes it will be very difficult to meet that family expectations. Like suppose some alarm is there, high blood pressure alarm, high heart rate alarm, and suppose we have not been there, that has been not attended. So probably family will feel that we are not doing our best because this kind of numbers were abnormal and we have not taken care of these numbers. So when at various places these kind of approaches have been used, they have used family surveys, and what they have found that the patient outcomes was better and complications were less, and staff feedback was also there. So we can probably some beds you can start these kind of family surveys and staff surveys if you open such beds to the relatives. So in conclusion, the family-centric care improves outcome for patients, families and providers. And family-centric care is not just a practice, it's a probably partnership of healing between, and it's a compassion. So what we talk in intensive care mode about humanization of intensive care. So whether it is one of the aspect of humanization of intensive care, where family is a part of as a care provider with us, and if we can probably empower them with that kind of background, education and support, probably our role will become for decision making slightly lighter and easier, and that's the hope in coming days. Thank you.
Thank you, sir, for the nice talk. I think they don't have any questions from the audience. This is a very sensitive area of family-centered approach in ICU setting. Most of us nowadays we have no medical provider has any sufficient time. So as a team approach, one person should be appointed to directly dealing with the patients and patients related. That is the I think most beneficial for our patients also.
but sometimes it becomes very difficult because recently in last 3 months we have segregated our 6 beds, and we are trying to those beds are made in such a way that we are allowing the relatives to be with the patient. Uh, but over the last 6 months, whatever experience what we have got is really challenging. It is putting a lot of pressure on our team, particularly staff. And I don't know that the balanced approach has to be there. And the area where I practice in is the suburb of Pune. So kind of class of patients which are coming, they are coming from periphery. So sometimes it becomes very, very difficult to make them understand that what kind of care we are giving and why this is important. But definitely it will be a gray zone. But going ahead, if we can empower and educate patients, relatives, and a subgroup of patients, that will definitely help us to. And that is the hope what we're trying to convert this. But there are a lot of challenges. Srinivas sir, I would like to hear from sir what sir views about family-centric care also.
Out of syllabus questions are difficult to answer. It is a concept of family-centered care is now an essential part of the ICU care in the West. But here, there are few challenges because in India, what is family? There is no definition, right? Your neighbor's friend, your neighbor's relative, everybody is family. And somehow, within the first 6 hours, we talk about 1 hour bundle, 3 hour bundle, 6 hour bundle. Somehow, our patients seem to find a relative either in the US or in the UK or in Australia within the first 6 hours of ICU, and that becomes family. So, but what I have practiced is at least for patients who are beyond 48 hours in the ICU, whom we know that this is a treatment plan, but the length of stay is going to be long. We have ensured that at least one re-identified family member, next of kin or a partner, is somebody who is allowed to sit with the patient unless they cannot see what we are doing. They are unable to see. Even during procedures, I allow them to sit with the patient and watch what we are seeing, explaining to them. I'm a pet lover. I'm an animal lover. And, I believe your pet is your family. And I honestly believe that if you can, in India, if you can allow your pet to come and have an interaction with the owner or the master or the family member for the pet, the mental balance is very important, is something that helps. As apart from family-centered care, what I have practiced is in the previous hospital where I worked, we used to have the students from the music college who are doing their PhD, who are doing their music PhD in music therapy. They used to come, know the native language of the patient, and actually sing the side of the patient. So the vasopressor requirement, the sedation requirement actually comes down. This is my observation. Similarly, if a close family member is actually speaking to somebody daily, even if you feel that the patient is deeply sedated, paralyzed, and not actually communicating with you, if somebody comes and starts speaking to them, you can see that their sedation requirement comes down, their agitation comes down, and you will be able to wean them off ventilator support much faster. This has been my experience in the last 20 years.
Thank you. So I think for my next talk, if I have a similar talk, I would add definition of family.
Thank you so much, Dr. Kapil Borawati, and the panel and the chairpersons, Dr. Parth Shah, Dr. Yogesh Waghela, and Dr. Kamlesh. We are playing a short video of Critical Care Conference 2025 at Kochi. Please see your registration, scan the QR code on the board. Please register yourself, scan the QR code on the banner for Criticon Criticare 2025 at Kochi. Now I would like to request Dr. Anish Joshi to come on stage. Now the most awaited session is here, the IPL finale quiz. Sir, over to you.
Can disturb the yesterday we had played an online quiz, and the winners, those who are available, in student category we have Satbir Agrawal, Dharan Modi, Hardik Dave, Jigar Ali Tejani, Captain Parmar Jai, Captain Darshit Chauhan, चार है ऊपर એટલે વેઇટ લિસ્ટેડ કેન્ડિડેટ્સ માં આઈ એમ ટેકિંગ સ્ટુડન્ટ નેમ માં શોએબ બાગ કેપ્ટન જીત ઠક્કર શ્વેતા કૌશલ હિનલ સુરભી વાદી વિશાલ પ્રજાપતિ in consultant category Mehul Gajjar Kunj Dr. Kunj Aneri Patel Knowledge Kumar Jitendra Kumar Pranav Patel Divyang Vyas Dr. Divyang sure I know ના સિંગલ કેન્ડિડેટ ઓછા થઈ ગયા ને તમે બે કન્સલ્ટન્ટ કેટેગરી વાળા છો ને 4 સ્ટુડન્ટ્સ અને 2 કન્સલ્ટન્ટ્સ અને દિવ્યાંગ હું સ્ટુડન્ટની નંબરિંગ કરું છું A, B, C, D, E, F અને G એવી રીતના તમને નંબરિંગ કરેલા છે ને કન્સલ્ટન્ટ સ્ટુડન્ટ કન્સલ્ટન્ટ તો પેલા કન્સલ્ટન્ટ કોઈ બીજા વાળા પૂછી દઈએ વિપુલ પટેલ અંકિત માકડ ધીરજ પટેલ સંજય હિમ્મતલાલ શેખ મયંક ખંજરવાલા સાથે યામાંથી કોઈ છે ઓકે શું નામ વિપુલ પટેલ क्या बोले एमांथी कोई अवेलेबल કેટલા છે સંજય છે અવેલેબલ તો આવી જાઓ કેટલા છે 3 5 ના અહીંયા સંજય છે આપે છે ને એક કન્સલ્ટન્ટ કેટેગરીમાં ને કઈ નહીં લઈ લો પેર પેર कर देनी पड़ता हाँ ठीक है हमारा आम पेर करनी पड़ते हैं 4 ના તો મેડમ એમને એવું કરતો પેલી વખત 4 છે ને એટલે અમને પેલી વખત લઈ દો હું ઊંધી પેર બનાવું બધું લઈ જાઉં તમારી ચેર સાથે થોડુંક કરવું પડે પણ હવે તો હવે હા પણ પેર કામ બનાવવી પડશે એક સ્ટુડન્ટ કન્સલ્ટન્ટ તો નાउ आई एम अगेन ના ના બસ હવે ડન again I am changing કે હવે મારી પાસે કેન્ડિડેટ થઈ ગયા એટલે વન સ્ટુડન્ટ વન કન્સલ્ટન્ટ પેર બનાવું છું તો તમારે એ રીતે બેસવું તો તમે એ રીતે બેસાડો તમે આ રીતે બેસવું તો તમે આ રીતે બેસી શકો છો રાઈટ ધ રૂલ્સ આર વેરી સિમ્પલ તમે પહેલી જે એક પેર છે और पेयर बनेंगे तो भाई अवेलेबल अवेलेबल करेंगे फिर उन पेयर में हम क्वेश्चन पूछते हैं you are team A the first chair consultant student in a team B team C team D in a team right બરાબર starting from here and going like this જ્યારે હું ક્વેશ્ચન તમને આપીશ તો તમે જો ક્વેશ્ચન કરેક્ટ આન્સર આપો તો you will get 10 marks as a team both of you માંથી કોઈ એક જ મને આન્સર આપશે એટલે you have to raise your hand so I can say that you are answering or he is answering right this is the team B is a 10 marks if you correctly answer તમને આપેલો ક્વેશ્ચન જો તમે નહીં એટલે મીન્સ ખોટો બોલતો તો તમને 0 માર્ક્સ આપીશ નેગેટિવ નહીં આપું તમે ખોટો આન્સર આપ્યો કે સાચો નથી તો ધેટ ક્વેશ્ચન વિલ પાસ ટુ નેક્સ્ટ ટીમ ધેટ ઇઝ ટીમ બી જો એ ટીમ બી જ્યારે આન્સર આપશે અને સાચો હશે ધેટ વિલ ગિવ +5 બટ ઇફ ધ આન્સર રોંગલી આઈ વિલ ડિડક્ટ -5 પાસ ઓન ધેટ ક્વેશ્ચનમાં +5 બોનસ છે હું સામે -5 લઈમાં લઈશ ઇફ યુ આન્સર રોંગ આઈ વિલ પાસ ઓન ટુ ધ નેક્સ્ટ ટિલ ધ ઓલ 5 ઇઝ કમ્પ્લીટ પછી ઓડિયન્સને ક્વેશ્ચન જતો રહેશે રાઈટ બીજું કંઈ તમારે પેર બનાવે તો હજુ તમને બી સફળ કરી શકું એમ છું હાથે કરી આપે ચલો દેટ વુડ બી બેટર તમને તો એ રીતે સેટ થઈ જાવ હા પણ પેર આવે છે એવી રીતે રાખે તો મને ઈઝી પડે ટીમ એ અહીંયા બેસે તો પછી એવું કરો ટીમ બી ને અહીંયા બેસાડીએ ટીમ એ અહીંયા ટીમ બી બેસાડ દો બે ચેરમાં હા टीम सी અહીંયા બેઠેલા મને ઈઝી પડે આમ ABCD ફેરવવાનું યુ આર ટીમ સી ને મેં અહીંયા ત્રીજામાં તો હા તો અહીંયા એક ચેર આવી એટલે ટીમ સી બની જાય ટીમ ડી ને ટીમ E ફાઇન ઓલ સેટ હવે ઉલટાને એ લોકો આવશે એ આવશે હા વાંચવું પડે એવું છે ઉગલીઓ ચાલુ થઈ જશે પહેલા ધડાકે તમને એવું થતા કે યાર બધું આવ્યું ડિસ્પ્લે ચાલે એવો છે દેખાતો ટાઈમર રાખી દઉં એટલે એવું નથી કે તમને કોણ મને કરોડપતિ જેવું ઇન્ડેફિનિટ ટાઈમ નહીં આપીએ એવું નથી પણ વિલ બી ગિવિંગ યુ 30 seconds time to answer the question our timekeeper and the mark keeper let she will tell time up પછી તમે આન્સર નહીં બોલી શકો હું નેક્સ્ટ ટીમને ક્વેશ્ચન પાસ ઓન કરી દઈશ ક્લિયર યુ ઓનલી વન એટેમ્પ ટુ આન્સર તમે પછી એકવાર એક આન્સર બોલી જાવ એ નહીં બી છે બી નહીં સી છે નહીં ચાલે તો એઝ અ ટીમ યુ હેવ ટુ ટેલ મી ઓનલી વન આન્સર જે તમને બેસ્ટ લાગે તમને લાગે બે આન્સર સાચા છે તો યુ હેવ ટુ સિલેક્ટ ધ બેસ્ટ વન ફ્રોમ ધેટ કોન્ટ્રાડિક્ટ કરે તો આઈ બી ગિવિંગ એન રીઝન કે ભાઈ મેં આન્સર કીધો છે હવે તેની ડિસ્પ્લે આપો ક્વિઝનું અને મને જે મેં લખ્યું છે એનો પૂરો આન્સર જોઈએ અડધો આપતો તો હું અડધા માર્ક્સ જ આપીશ એટલે હું નક્કી કરીશ કે તમે પછી પાર્ટ આન્સર બોલ્યા કરો તો આઈ બી ગિવિંગ યુ પાર્ટ આઈ મીન 50% માર્ક્સ કારણ કે આમાં અડધું તમે બોલી શકશો અડધું થોડું અઘરું છે એવું છે અને હા ભાઈ નો મોબાઈલ નથી એટલે મારે લેવા નહીં પડે પણ Be fair અને મોબાઈલ ખિસ્સામાં એટલે નો ગૂગલિંગ ઓફ ધ ક્વેશ્ચન કારણ કે નીકળ તરત આન્સર મળી જશે. Start with the first question. Identify name, achievement or importance of this doctor. Team name.
Pass.
ऑडियंस માંથી કોઈ પલ્મો બેકગ્રાઉન્ડ વાળાને ખબર હશે? મિનેશ બહુ ફેમસ પર્સનાલિટી છે અને કેમ એમને લીધા એનો રીઝન હા ગૂગલ નહીં યાર ગૂગલ કરતો તરત આન્સર મળી જશે ગૂગલ લેન્સ ચાલુ કરતો હતો તો મારી આટલા દિવસની મહેનત પાણીમાં કરતો હું આન્સર આપી દઉં કોઈને માર્ક્સ નથી મળતા. જીતેન્દ્રનાથ પાંડે ઇઝ અ ડોક્ટર અને ઇઝ અ પલ્મોનોલોજીસ્ટ બાય પ્રોફેશન અને એમને મેઇન પદ્મશ્રી મળેલો આફ્ટર he expired during his COVID duties. So he is a pulmonologist with the Padma Shri Award. Dr. Jitannath Pandey. He was working with Sitaram Bharti Institute at New Delhi. Next slide. Team B માટે. Identify name, achievement or importance of this doctor.
Pass.
Pass. જલ્દી પ્લીઝ પતી જશે. ઓડિયન્સ માંથી કોઈ નો ગૂગલિંગ. He is Dr. M.R. Raj Gopal. He is known as father of palliative care and he is also a Padma Shri winner. So next slide. આ તો આપણે જોઈએ. So team C. Identify the hospitals and what is their importance in critical care. ये हॉस्पिटल में बता दीजिए. पास. 0-0 पर जब बताया. ऑडियंस नजीक छो. एक मिनट. કઈ નહીં ચલો આપણે અત્યારે સાવ 0 ઉપર ચાલે એટલે ઓપનિંગ બેટ્સમેન તરીકે બંને કેવી પડે મને બંને કેવી એમ છે કે ક્રિટિકલ કેરની કોન્ફરન્સ હોય ને તો કંઈક એના સેશનમાં મેં લીધું હોય એટલે આ એના માટે નહીં કે બાકી બધી વસ્તુ મારી આના પોતાના મૂકું. પહેલી કી એમ છે ચલો ડન એગ્રી સાચો આન્સર છે. એનીવન ફ્રોમ ધ ઓડિયન્સ? બ્રિજ કેન્ડી અમે આઈડેન્ટિફાઈ કરીએ હવે વોટ ઇઝ ધ ઇમ્પોર્ટન્સ ઇન ક્રિટિકલ કેર. સેકન્ડ ક્વેશ્ચન ઇઝ ધેટ what is the importance in critical care? કેમ આ હોસ્પિટલમાં લીધી? What is the main reason why I put this photograph? What is important?
તો બીજા કોઈનો ફોન
હા,
આવે
કોણ
નીચે
બોલે?
આવીને હું કેમેરામાં છું.
Yes.
અરે
These
આનું
are
કોન્ટેક્ટ
the two first critical care units which were started by Dr. Farooq Udwadia. One was in a private setup and another was in a government setup. એટલે એનામાં ઇમ્પોર્ટન્સ છે. એ થોડુંક લિબરલ વેલ્યુ એટલે આપું છું નહીં ના અપાય. ચલો ટીમ ડી માં જઈએ ને. ડી. Identify the name, achievement or importance of this doctor. નેશનલ કોન્ફરન્સ અટેન્ડ કરી તો આન્સર મળી ગયો. કન્સલ્ટન્ટ કોણ છે મારી તો વિલ કમ ટુ યુ. પાસ પાસ. ચલો સાચું છે એટલું સાચું છે. શીરીષ પ્રયાગ નામ છે. વોટ ઇઝ ઇટ અચીવમેન્ટ ઓર ઇમ્પોર્ટન્સ? પૂનામાંથી એ તો કંઈક પૂનામાં હશે ને એટલા માટે મેં પૂછ્યું હશે. હા એટલે ઇઝ ડોક્ટર શિરીષ પ્રયાગ ફ્રોમ પૂના અને એમણે પણ ત્યાં જેમ આરુ બુધવાડિયા સાહેબે ચાલુ કર્યું એવી રીતના પૂનાની અંદર ઈ સ્ટાર્ટેડ ક્રિટિકલ કેર સોસાયટીનો ફર્સ્ટ આઈસીયુ ઇન પૂના સ્ટીલ પ્રેક્ટિસિંગ મારા સાહેબની ઉંમર થઈ ગઈ એમના સન હવે પ્રેક્ટિસ કરે છે. આમનો જ ક્વેશ્ચન અમને જતા ના પાસો નથી હતો તો એ 5 માર્ક્સ આપી દઈ ગયા છે. ચલો ટીમ ઈ identify the name, achievement or importance of this person. Pass. Audience without feeling. Anesthesia background વાળા તેને આવડવું જોઈએ હો. ગીતા ઓફ એનેસ્થેશિયા એવું કહી શકાય. ગૂગલ કર્યા વગર મને આન્સર આપો. ચલો હિન્ટ આપી દઉં. વેન્ટિલેટર રિલેટેડ છે. ચલો yes, he is Martin Tobin who has written a famous book on mechanical ventilation. Right? 0 marks. चलो नेक्स्ट टीम कौन है? ए नहीं पास. बी सी डी ऑडियंस हमको मन लगे थे. ऑडियंस हिंट आप लो. ओके एक જ વાર બોલી તમે બધા આન્સર બોલી કાઢો. પોઈઝનિંગ બોલો હવે. આટલું તો હિંટ આપી દીધી यार. આગળ વાળા ઓર્ગેનાઇઝર ના ચાલો તમારી જોડે પૈસા લઈશું હવે. આટલી મહેનત કરી ક્વિઝમાં. He is Louis Goldfrank who has written a book on toxicology. Goldfrank's toxicology book कही है. Here we end our first round of identifying the personalities. Now you have to identify क्या अटकेला है. So now I will be giving you a logo of the society and you have to tell me the name of the society. આખી સોસાયટીનું મારે નામ બોલવાનું છે. એક ક્રિટિકલ કેર અથવા એના રિલેશનમાં સોસાયટીનો લોગો હશે. ફર્સ્ટ સ્લાઇડ. ऑडियंस नाम बोलता हूँ कारण कि लिटिल बिट इजी. पास.
માઈક આપ્યું માઈકમાં બોલો.
નેગેટિવ માર્કિંગ કાઢી કાઢો છું. બહુ હાર્ડ લાગે છે એટલે આઈ એમ રિમૂવિંગ ધ એટેમ્પ્ટ.
FCCM વાળી સોસાયટી.
આ સોસાયટીનું નામ જોઈ લે છે બધી ક્રિટિકલ કેર. એટલે પાછળ તો ક્રિટિકલ કેર સોસાયટી આવતા પણ મને આનું નામ તો આપો. See, this is what we are daily seeing such logos in our daily life. તમે ગૂગલ કરીને પબમેડ ઉપર આર્ટિકલ વાંચતા હશો, જ્યાં ત્યાં બધા બ્રોશર જોતા હશો, કોન્ફરન્સીસ જોતા હશો, પણ તમે લોગો નથી આઈડેન્ટિફાઈ કરી શકતા. સો ધીસ ઇઝ અવર વિઝ્યુઅલ. હા,
Respiratory journal.
this is society. This is not a journal. I'm very, very clear. I have taken this from the website of that particular society, the logo. Stage ઉપર anyone wants to answer? Negative marking નથી રાખતો. ચલો near, you are somewhere near to that. જાઓ તો ઓડિયન્સમાં સાચો આન્સર નહીં કહું તો એ 5 રૂપિયા છે. SCCM, that is Society of Critical Care Medicine. Next slide. કોને આવે છે? C. Identify the society. મેહુલ. No, not related to cardiology. Be any critical care conference. Probably whenever. No from stage. मीने હવે બીજાને ચાન્સ આપીએ. હા સમીરભાઈ का એ બધા ઉપર આપણે કમિટી સિવાય કોઈ anyone else from the audience would like to answer this question? એક મિનિટ હા yes. True. આપણે પ્રિલિમિનરી ડેલિગેટને ચોઈસ આપી દો સ્ટુડન્ટ કેટેગરી ગ્રીન બેચ ને થર્ડ સ્લાઇડ તો યુ છે ને ક્વેશ્ચન E team. No one from stage? Audience. Delegates preferably. चलो committee. World Federation of Intensive and Critical Care. चलो fourth. જે બહુ પડતા એને તો ખબર હોવી જોઈએ યાર તમે બધા જાઓ છો ચલો કોને તમને જે કોને ચલો આઈડેન્ટિફાઈ નીચે લખ્યું એના ઉપરથી હિન્ટ છે તો નેગેટિવ માર્કિંગ નથી રાખતો
Society of China.
Taiwan, Korea.
Korean Society of Critical Care Medicine. આપણ એટલે મેં કીધું બોલવાનું નહીં હવે તમે કહી દીધું એને બોલી કરો તો એને માર્ક્સ મળી ગયો એટલે મેં કીધું કે કીપ ઇન યોર માઇન્ડ ઇફ યુ નો ઇન નેગેટિવ ને નેક્સ્ટ ચલો હુ ઇઝ ધ નેક્સ્ટ એને મનમાં રાખજો જો આવડતું હોય તો નો 0 માર્ક્સ કારણ કે એમને હતો ક્વેશ્ચન એનો માઇનસ છે આઈલે 0 માર્ક્સ આપવાનું ટીમ બી
માર્કિંગ નથી તો વિચાર તો આવી નથી
ભાઈ ખાલી કીધું કે રૂલ્સ ચેન્જ કરી કરે આપો એટલે તમે છેલ્લે બોલ્યો તમે આટલું પરફોર્મન્સ આપો તો મારે છેલ્લે કાઢવા જ પડે ને આટલું તો બોલાવો ઘણા વાર છાતું નથી બોલાવ્યું
ફૂલ ફોર્મ બોલવા માટે તોય ખબર પડે તમને
ચલો ટુ ધ ઓડિયન્સ ગૂગલ કરેલું છે ને नेपाल सोसाइटी ऑफ क्रिटिकल केयर मैगजीन हाँ either I am deaf or you spoke softly आपी जाइए चलो ऑडियंस बोल के जाती हो Parul tell the total tell the man but we move to the next round
Mike Mamur
Mike Mamur नहीं है
Team A 10 marks, Team B 5 marks, and Team E 5 marks.
10 5 5 બીજા ખાતું ખોલાવ્યું નથી રાઈટ we move to the next slide અરે ગઈ ઉપર હા ચલો
આંસુ પડ્યા આંસુ પ્રોબ્લેમ
આપી દઉં છું બોલવું છે અઘરું છે બરાબર છે એટલું સાચું છે. એને સ્પેશિયલ નથી, ચલો જેવું છે, એને સ્પેશિયલ નથી. એલાઇડ છે, ક્રિટિકલ કેરની નથી એકચ્યુઅલી, ક્રિટિકલ કેર છે.
સિમ્બોલ ને ગેસ કર તો તને ખબર પડશે.
હા
વિચાર તું આ નથી તો સિમ્બોલ ને ગેસ કર કે આ શેનો સિમ્બોલ છે ને શેના રિલેટેડ હોય છે. અરે નહીં સર થોડી હિન્ટ જોયું નથી પણ ખબર પડે એમ કે આ કંઈક હોય છે.
I can give you marks for answering little bit. And anyone from the state would like to answer this? Totally बोलो if you want to try. No.
Hematology.
No. No. Google ના કર્યો તો કોઈ from the audience? European Society of Clinical Nutrition and Metabolism. 5 marks. Liberal રહી ગયેલો એમ મળે. ચલો one liner, short and sweet, one liner questions. ચલો female. Yeah, we'll be keeping time, no? Make a person.
3 સેકન્ડ એ પાસ કરે.
D, correct answer. 10 marks to team C. Next slide. About meeting now. Which is the only level 1 guideline as per brain trauma foundation for traumatic brain injury. મેં કહ્યું સાચું છે. That is your to tell me. Yeah, true. 10 marks to you. Next slide. Next team. The most common acid-base disorder in liver disease is answer more negative marking here. Fast. Wrong. Next team.
આવશે ટર્ન આવશે.
ટીમ એ બોલે.
એ નહીં બોલે તો બી
ટીમ બી. ચલો આપી દઈએ છે. ટાઈમ ઓફ હતો પણ આપી દઉં છું. હું જસ્ટિફિકેશન જોઈને મારી પાસે બધાના આન્સર છે પણ જો તમને ક્યાંય ડાઉટ એવું લાગે કે આ હું ખોટો બોલું છું તો આઈ હેવ રેફરન્સ. Which are the following indication for cholecystectomy? કઈ ટીમ છે? ટીમ એ. True, 10 marks. Next slide. Incorrect. True, 10 marks. Next slide and next team is false. 10 marks. चलो हम जाइए ना क्वेश्चन टीम डी चलो मेडिकल लीगल ऊपर लगी है तो फर्स्ट क्वेश्चन द पोलम टेस्ट is the relationship between whom
टाइमिंग में सीख रहा था
C wrong answer next team હવે તમારે નહીં વિચારો તમે ડિબેટ ટાઈમ મળી ગયો either you speak or you pass આમાં માઇનસ રાખી દો કારણ કે these are one minus if you speak incorrect I'll take out your minus 5 means I'll take 5 from you so if you know tell me or pass elephant America E for elephant incorrect minus 5 चलो टीम ए हाँ तो इनफ છે A for America true plus 5 next slide कौन सा आंसर क्वेश्चन हाँ हम माइनस लाइक्स kind of the one liners wrong team next team true plus 5 to a team A next slide चलो B for Bombay. Yes, true. It's not an absolute contraindication. It's a relative. चलो 10 मार्क्स आपके हमने टीम B Apple ની વોચ છે you have to tell me the special feature of software in relation to the monitoring એટલે આપણે ક્રિટિકલ કરી દીધું બીજા બધા મારે એબ્સેન્ટ થઈ ગયું tell me anything ચલો हाँ हाँ હવે મારે સોફ્ટવેર નું નામ જોઈએ છે that is what my question is software in relation to this Apple watch
આ સોફ્ટવેર થી તમે જોઈ શકો એપલ વોચ માં
ઓપ્શન આપો તો આન્સર મળી જાય તો તમારો ઓપ્શન નતો રાખ્યો સોફ્ટવેર નું નામ જોઈએ that is my ये SQL આપે છે બધું બરાબર છે anyone from the state team even if you tell me partly I'll be giving you marks but you have to be near to that name of the app or something closely anyone from audience irregular rhythm notification feature is a software only app on Apple Watch that detects irregular heart rate and notifies the user. Any proprietary software no naam je. Next. Irregular rhythm notification feature app no naam je. Next. Team C. Incorrect. As per Society of Critical Care Medicine 2024 guidelines on sugar control for critically ill patient, which is wrong. is wrong answer. Next team D. फटाफट और D for Delhi. Wrong answer. Ah, yes. A is the correct answer. Plus 5 to team E. It should be done when the RBS is more than 180, not 200. in ISCCM guideline 2020. What is the correct recommendation? Team, what is the correct recommendation for tracheostomy as per ISCCM guidelines 2020? Incorrect. Go to. Now I take, if you are incorrect, I'll take mine. E4 Bombay, -5. छोड़ दीजिए, the answer is correct answer is D. The percutaneous dilatation tracheostomy is more cost effective as compared to surgical tracheostomy. Right? मार्क की दो भाई, केस निकालना चालू करिए. Fast. हाँ तो आ केस राउंड है ना, પછી છેલ્લે પેલો એક ફોટો રાઉન્ડ એને સાથે પૂરું કરીએ. હવે કોણ કઈ ટીમ આવે? બાકી है ना, फर्स्ट केस टू यू. तेजस भाई आपकी डिस्प्ले रितेश वाचो બે પાર્ટમાં છે. ફર્સ્ટ સ્લાઇડ છે, સેકન્ડ સ્લાઇડ આવશે. હા ઈ પછી છોકરો નાખ મારે ફટાફટ. Should we move to next slide? Answers on.
So C.
Wrong. Only is -5 days. B. Pass. B. Team. E is the correct answer. +5. Next slide. बोलो बोलो फटाफट, તમને 0 मार्क्स મળે, ફૂલ માર્ક્સ. Delhi, D for Delhi, incorrect. B for Bombay, right? Correct. +5 to B. Next slide. અમિત પણ નથી ને, અમિત તને ખબર હોય પણ આન્સર ના બોલ, ઝઘડો કરે તો આન્સર ના બોલ. યાદ આવે ને? યસ યસ, સદગુરુ. તમારો છે ને આન્સર ઇઝ 4. Wrong. Next team. હવે ફટાફટ કરજો, you also write the question. અને otherwise pass. માઇનસ આપી દીધું. બંનેમાંથી નક્કી કરો. 2 is the correct answer. +5 to team C. કલ્પનાજી કામ આવે છે. Oricon હતો. Correct, 10 marks. Next slide. Team D.
Be fast, please.
B for Bombay. Incorrect.
Sir, D.
D for Delhi. Incorrect. +5 આપી દઉં છું. 3 વાર દઉં પણ આપી દઉં છું. +5 to team A. Next slide. Team E. બીજી બધી ટીમ રેડી રહેજો. આન્સર સાથે ક્વેશ્ચન પાસ કરીને બહુ ટાઈમ નહીં પકડે.
લાસ્ટ યરનું રિપીટ થયો તો ફાયદો.
What is shown એટલું મને કહી દો. ચલો what management will you do કરતા what બે ક્વેશ્ચન છે નીચે લખ્યા છે A અને B. What is the most likely cause of the hypotension? If you can tell me, I'll give you full marks. It is your gone down arterial pressure hypotension જરૂર છે. What is your diagnosis? Little bit more specific. You are near, but I want a specific answer. Looking at the CVP graph, can you tell me something? You are correct. Marks happy these children. But what has happened to CVP and the hypotension and ETC has gone down? It's basically an air embolism, but 10 marks happy to team E. Next slide. Last round, tell the company name. You tell me the company name and the taglines. जो कंपनी नेम खाली बोलो तो 5 मार्क्स આપીશ. આમાં નેગેટિવ માર્કિંગ નથી રાખતો. રાઈટ? અને છેલ્લે પણ બસ 2 મિનિટ પતી ગયું. You have to tell me the pharma company name and its taglines. ચલો. એમને બોલો તો માર્ક્સ ખબર છે. Pfizer tagline.
બેઠા છે પાછળ ફાર્મા.
Anyone from the stage who can answer the tagline? From the audience, tagline of Pfizer. Anyone?
કાપલી હતી એક્ઝામની કાપલી લગાડી
કઈ વાંધો નહીં. બોલો બોલો. Breakthrough that changes patient lives. That is the tagline of Pfizer. Team B, identify and the tagline. 5 marks આપી દે. બીજા 5.
ટેગલાઈન બોલો. હા મેં જોતો સપોર્ટ પર
સ્ટોલ બરાબર કર્યા નથી એનો બીજો મિત્ર.
સપોર્ટ મનોજ ભાઈ.
નેગેટિવ માર્કિંગ નથી બોલો યાર. Life matters wrong. Anyone from the stage? નજીક છે. Near to that. Dedicated to life. Dedicated to life is the tagline. Third. CNN. Logo means the company and its tagline. D, E, A team, B team, audience. गोपाल भाई नहीं बोले सेकंड में नहीं बोले तो कौन जाना मीन तो नहीं बोले. Venus families is the correct answer and what is the tagline? No. જે તમે અહીંયા એન્જોય કરો છો એવું એન્જોય થવું થાય. ચલો નહીં. Enjoy innovations.
Always support Gujarat Criticon.
तेजस्वी बताओ आंसर आंसर बताओ नेक्स्ट स्लाइड नेक्स्ट लोगो टीम डी फटाफट कंपनी नेम टीम ई ए रेडी आंसर करेक्ट टैगलाइन 5 मार्क्स आते हैं विनर टैगलाइन फ्रॉम स्टेज टैगलाइन फ्रॉम द ऑडियंस
Ready वाला ने
the correct answer the 5 marks to team A good health can't wait E team E name tell me the company name and its tagline स्टॉल नहीं करे एनो नहीं दो
पांच जगह बता
BDR pharma correct answer tagline anyone from the stage ऊपर वही है टैगलाइन अमरीश क्या है अमित
हमें टैगलाइन ना
अमित है ना
हमें कंपनी का नाम इश्यू है
लोग
नेक्स्ट टाइम याद रखनी
प्राइस टैग
adding years to life and life to years that is the tagline
ગૂગલ એ દેખાડતી કે
ચલો next
ફાર્મા પીપલ છે ને આપડા બધા પ્રજાપતિ છે
લોકોમાં જ હિન્ટ છે જો તમે શોધી શકતો હતો કઈ ટીમ ઈ છે ને એ છે કોણ સ્લાઇડ છે પતિ ભાઈ પૂરું કરી દે પૂરું કરી દે નહીં anyone from the stage नहीं audience clear what is the tagline extended life care beyond boundaries
અમરીશ આર્ટ પેપર કાઢ્યું હતું તું હવે બેટરી વાળો ખીચી જતો
mankind પણ આ તો બધાને આવડે મને આનો ટેગલાઇન કેવી પડે અને આ તો બધાનું મોડે હોવી જોઈએ બહુ કોમન છે હા yes true marks આપી દો છો serving life is the correct tagline આ ટાઈમ આપી દઈએ
આની ભૂખ લાગી છે મેડિકોપ જોઈને ભૂખ લાગી બીકોઝ
મેડિકોપ છે ટેગલાઇન કો ચલ
ના મેડિકોપ સપોર્ટેડ ગાલા ડિનર યસ્ટરડે
thank you medicop for supporting our gala dinner leading the way to better health is the tagline અહીંયા we are ending the quiz Parul will tell the marks and then Dr. Mehul come on the stage first prize is 5,000 each to the each person so there is 10,000 second prize is 3,000 each and then the third prize is 2,000 each એ વિનર રાખેલું છે ચેક તમારે ઉપર લઈને પકડવાનો Parul will announce the team names the first second third
મેડિકોપ ની લાગી કાકી એટલે પછી સીધા બતાઈને
મજા આવી ક્વિઝમાં
એક્સેલન્ટ
અમારા ડોક્ટર ટીચર અને ડોક્ટર પારુલ they helped me in making this quiz
આવો બધા જ એસ્પેક્ટ કવર કરે
This is also an accessory part of Gujarat Criticon.
Yes.
winner team A winner congratulations
Team E got 50. Yes.
second prize to team B
And team C is 35. Third.
બાજુના રૂમમાં
congratulations wait anybody
એ આ તો APL એ BBC
And the D and E, both of them, they got 5 marks each.
સાચી વાત હતી
The felicitation for quiz winners will be conducted just in a few minutes.
ना ना बताई दो ने बताई हाँ अले
Sir, I would like to call on stage Dr. Amrish Patel to felicitate the first prize for quiz. I would like to call on stage Dr. Bhavesh Shah to felicitate the second prize for quiz. Big round of applause for all the teams, please.
फोटो भाई
I would like to call on stage Dr. Vipul Thakkar for felicitating the third winners of the quiz.
ये अनाउंस कर आई गयो ना ना फोन आ
Please stay for a picture.
थोड़ा बच्चे બધા સેન્ટર માં સાંભળો બધા વિનર ભાઈ
બધા quiz winners અને
પેનલિસ્ટ આને ક્લિનો લઈ બધા ઉપર સેન્ટર લોગો આવે અને વચ્ચે સેન્ટર રે હવે બધા આવી જાઓ આખી ક્વિઝ ની ટીમ અનિશભાઈ લીડ કરી તેજસભાઈ ક્યાં ગયા તેજસભાઈ હા તેજસભાઈ છે હજુ થોડા મિડલ માં આગળ અને થોડા યા ભાઈ સાંભળા ખુરશીઓ લેવા લાઈન માં આવી જાવ લાઈન માં તમે પેરેલલ પાછળના હા વેરી ગુડ
Thank you so much. Thank you so much, Dr. Anish Joshi sir, Dr. Tejas sir, for conducting an amazing. Thank you for all the participants. Now, moving on. Every year, first prize for oral paper presentation in all GUJCRITICONs in the past year and even this year have always been awarded by ISCCM Karam sir in association with Shivani Bhatt Charitable Foundation. The first prize is worth ₹20,000 cash prize. To felicitate the winners, I would like to call on stage Dr. Sameer Patel and Dr. Anand Mishra.
ભૂખ લાગી છે પણ તારીઓ પાડે છે સારું એક થોડા આગળ આવવાનું
First prize goes to Dr. Rachit Patel.
आज चेकिंग છે ગરમ સાદનું કામ ગરમ સાદમાં થયું ઈ ખીચડીમાં છે
Second prize Dr. Prince Desai. First prize Dr. Rachit Patel. Second Dr. Prince. Is Dr. Prince available or someone can take his?
हेलो भाई बदल डिटेल जाकी अरे अमित भाई हां भाई आपका फोन दवा नहीं हां
Like to, now moving on to poster presentation, I like to invite Dr. Raj Raval sir. Dr. Tate. The winners is the first prize goes to Dr. Manan Shah. Dr. Tejas, invite you on stage to felicitate our second winner, that is Dr. Dushyant Vaidya. First winner, Dr. Manan Shah. Dr. Dushyant Vaidya, is he present? Anyone from on his behalf?
Sir is giving, sir is taking.
Third winner is Dr. Riddhi Patel. Is Dr. Riddhi Patel available? Okay. Dr. Rachit sir is taking on. I would like to invite Dr. Minesh Patel to felicitate.
Rachit. हॉल में आ जाओ पहले से कर लो मेन वॉइस
Last today we have excellent 4 cases and was judged by Dr. Raj Rawal and myself. So first case presentation winner is Dr. Riddhi Patel. And the prize which is given by our beloved friend Dr. Raj Rawal. And collect from Raj if you can get it.
all pharma people please બધા તમારા કલીગ ને અહીંયા બોલાવી લો એક મોટું ફોટો સેશન કરી દો પ્લીઝ જેટલા બી ફાર્મા પીપલ અહીંયા બેઠા છે એમના બધાના કલીગ અને નેબર સ્ટોલના બી ફાર્મા છે એમને બોલાવી લો અહીંયા આપણે ફોટો સેશન કરવાનું પ્લીઝ.
Second is Dr. Parth Shah. Dr. Raj Rawal પસંદ કરે ને એટલે બહુ મોટું નામ કહેવાય. Third is Dr. Darshit Chauhan. Third case. Darshit આજે ખુશી ભરેલું છે. Once again, requesting all pharma friends, please call your nearby store and your colleagues also. We will have a good photo session. શુદ્ધ ગુજરાતીમાં તમારા
ભાઈબંધો.
After finishing this scientific session, I would like to felicitate our main academic partners for from starting off કે જ્યારથી આપણે program decide કર્યો on very first day they are always with us. So એ જે 4 main academic partner છે એને हम लोग on behalf of our academic committee first Pfizer માંથી કોઈ છે Pfizer company please yes પરેશભાઈ આવો તમે પછી સિપ્લા ભરત yes then United Biotech is our academic kit sponsor then Medicop they are academic gala dinner sponsor so one by one પરેશભાઈ Pfizer માંથી આવો please પહેલા please welcome on stage પરેશભાઈ ગોપાલભાઈ I request Gopalbhai, Mehulbhai, Amit, Divyang, Rajbhai. બધા ફાર્મા સ્ટોલ પ્લીઝ આગળ આવી જાઓ બધા પ્લીઝ આપણે ફિનિશ કરીએ છીએ પ્લીઝ આગળ આવી જાઓ ગોપાલભાઈ મનોજભાઈ મેહુલભાઈ ગોપાલભાઈ મેહુલભાઈ
ફાઇઝર ટીમ તમારે બોલાવી છે.
ફાઇઝરના બીજા મેમ્બર્સ
ફાઇઝર ટીમ પ્લીઝ એક સાથે ચલો.
સિપ્લા એની ટીમ સાથે તૈયાર રહે.
બધા ફાર્માવાળા પ્લીઝ આગળ આવી જાય.
બાયોટેક
આગળ આવી જાય.
પછી મેડિકો
આગળ આવી જાય બધા ફાર્મા. રાજભાઈ, મનોજભાઈ,
નીશભાઈ પ્લીઝ. જોરથી તાલીઓ. Next, Sipla for providing excellent academics support for making this 10th Gujarat Criticon at a very huge success level. Thank you, Team Sipla. Then United Biotech.
United Biotech is our kit sponsor.
Thank you, United Biotech.
Vipul bhai, on please. Vipul bhai. Vipul bhai. United Biotech is our kit. Thanks to the United Biotech team. For the next
Medicop company, Neeraj, they have provided excellent support and providing support for gala dinner. Neeraj, please. બધાને ભૂખ લાગે છે પણ થોડું એક તાળીઓ પાડી લઈએ.
ભાવેશ ભાઈ પ્લીઝ. ભાવેશ ભાઈ.
કમિટી મેમ્બર્સ જ્યાં હોય આપણા ઓર્ગેનાઇઝિંગ એ પણ બોલાવી રહેતું ચાલો. We are doing a group studies.
Thank you. આપણે ખાલી ઓર્ગેનાઇઝિંગ ટીમ બધા જ મેમ્બર પ્લીઝ સ્ટેજ ઉપર આવી જાય પ્લીઝ. અને બધી જ હવે ફાર્મા કંપની ટીએક્સ બધા એક સાથે આવે. પહેલા ઓર્ગેનાઇઝિંગ ટીમ આપણી ઉપર આવી જાય પ્લીઝ. દિનેશ
આયો.
ના ઝૂમ આઉટ ઝૂમ ઇન તો કરવાનું બાકી
ઓર્ગેનાઇઝિંગ ટીમ પ્લીઝ કમ ઓન યોર સ્ટેજ.
પણ આમાં જો આ છે ને આમ પેલું
કોઈ નીચે બેઠા હોય તો
માટે બ્રાઇટનેસ માટે
આવી જાઓ ફરી
પ્લીઝ. બધા ફાર્મા કંપની રેડી રહેજો. નામ બોલો એક બધા સ્ટેજ ઉપર આવજો. આપણે બીજા ઓર્ગેનાઇઝિંગ ટીમ પર ફાઇન. હું બીજા એકેડેમિક અમારા જે બીજા પાર્ટનર છે આજે છે 4 મેઇન સ્પોન્સર સિવાય હું ઇન્વાઇટ કરીશ. હોસ્પિકેર આલ્કેન પ્લીઝ.
સ્ટેજ પર આવીએ બધા.
એરિસ્ટો ફાર્મા પ્લીઝ. ડી બ્રાઉન, BDR એને કોઈ રિપ્રેઝેન્ટેટિવ છે અહીંયા? આલ્કેન પ્લીઝ. એરિસ્ટો ફાર્મા, ડી બ્રાઉન,
BDR, BDR, thank you. Polo Class, Concord Biotech, Converge, Criticon, MCure Pharma, please come on the stage. Penclay, President's Cabby, please. Thank you everyone. Glenmark, Yufi, thank you. Yufi, Glenmark, Hexagon, Intas Pharma, La Renon, Lipot, Intas Pharma, La Renon, Lipot, Lupin, Mankind Pharma, please. Medimark, Pranav Healthcare, Novak Ventilator, Philips, Poland, Polymed, Reliance, Steeler, Sterling Accuracy, Zydus Pharma, Zydus Hospital, Teleflex, Takeda, Venus Remedy, Mylan, Vinhill, Juventus, Zydus Pharma, Giants, Dr. Reddy, Cadila Pharma, Novartis, Arju, એના સિવાય કોઈ કંપની રહી ગયો તો એ બી આવે પ્લીઝ. વેદ મેડિકલ, hospital partner are Sterling Hospital, Zydus Hospital, Marigo 6 Hospital and KD Hospital. Pneumocare. So thanks everybody for contributing for the 10th GUJCRITICON 2024.
First, thank you very much for your active involvement, particularly being an academic partner, and we always looking forward for your presence because you are a technology or innovators. Okay, so if you are bringing some new molecules, new techniques, and new innovative idea into medical fields, then it will be a great contribution to our fraternity. So we have to combine together to improve our educational activity. So once again, thank you very much for being your active academic partner. Thank you. I would like to also thank our committee team as well as medical college for giving us permission for organizing a workshop. So each and every person, those who have actively involved in making these Gujarat 10 GUJCRITICON at a very huge remarkable level. So again, thank you very much for every committee member. I would also like to thank you, Mr. Rushil and his team for providing a registration support, Club Babylon, as well as Mr. Baljit for providing a designing and other logistic management also. Thank you everyone.
last as an organizing chairman of this 10th Gujarat Criticon, I am very much thankful, first of all, my organizing team with all delegates who spent their valuable time in workshop and these 2 days, all sessions, scientific sessions, pharma as usual academic partnership, and all the supporting staff, like start from audiovisual and from registration, food person who is serving a very delicious food, and audiovisual person, cameraman, they are catching good snaps which will be remembered for long, long, long time. So if I forget anyone, please beg us pardon, and thank you so much, and we will soon meet at 11th Gujarat Criticon at Surat 2025. Thank you so much, and please come for a lunch. Thank you.
Done very good. Learn to have a very program आने पर आप